Hey, good morning. Good morning, everyone.
Yeah, hello, Dr. Bahadir. How are you? This
Good
is
morning.
Anjali.
I'm very good. How are you doing today?
Yeah, it's fine. So let's wait for half an hour so that
For
everyone
sure.
can join. Is that
I'm
okay?
trying to share my slides. It seems the host is not allowing me to share my slides. So can you allow it?
Let me check. Yeah, hello, doctor. I have allowed the access. Could you please check out?
Yes, it's yeah, desktop one. Only system setting. Let me see. Uh, Zoom. Okay. Oh, I think I have to go out and rejoin. Let's do it. All right, desktop. That's good. So let me open my presentation.
Yes, doctor, we can see the screen.
Good. I'm just like preparing myself so we can, once we start, everything will be ready.
Okay, but we need to wait another 20 to 25 minutes so that
No, no, no. I'm just like making sure everything is working on my
okay,
slides
okay, okay,
so
fine,
the
fine.
audience can attend.
That's great.
Oops, what's happening to the slide? Just need to add. That's good. That's good. Blank, insert, type down zoom.
Hello, good morning, everybody.
Hi, good morning.
Hello, good morning, doctor.
Good
It's
morning.
like 4 minutes to this is a very nice to see everyone on this meeting. And I think this is a promising start for us to start like small group of consistent, probably like every few months, like we can do a similar meeting. And every time we can like share our cases, share our knowledge, and that will help, us first to learn from each other, and the second, we can, build up our like social international connections. We know that we are in the era of, multiple international webinars, right? But I don't think it's attractive to anyone to attend, because like you see webinars or like every now and then, and a different speakers. So this is, I would say, this is just a start. This is the idea of starting a consistent a webinar, and we will, like, if everyone agree, we will keep consistently doing this webinar on a regular basis, either every, like, I would say, a few months or on a yearly basis. And I do believe if we stay consistent on this webinar, with time, we will have like more audience. Like if we were consistent, and overall, the idea is to share knowledge and learn from each other about the techniques and how everyone, deal within with surgical cases, neurosurgical cases in his practice. So we will ask the audience before they speak to like give a brief introduction about himself. I will be the first speaker. My name is Bahadir Mohsen. I'm a consultant neurosurgeon working currently in Saudi Arabia, Dr. Suleiman Al Habib Group in Al Qasim branch. I just recently joined the hospital, and I started my practice, independent practice. It's not a quite big experience, but I was able to build a good number of high quality cases to speak in the webinars. So before everyone starts his presentation, we have a minute to go. Once I'm done, like the next speaker will introduce himself and give a brief description about his practice. My practice mainly is like general neurosurgery, and I do some, interest in tumors, either intraaxial or skull-based tumors, but I do as well the general neurosurgery cases in my practice. Pete, are we ready to start? We need your voice with us to let us start. I think we are on time now.
Yeah, hello, doctor. So it's the day has been came which we have waited for so many days, right? So I welcome to all the speakers and waiting for the other speakers also join. But as I can inform you that there were several timings at different countries. So it will take some time to join everyone, but that's okay. So let me welcome all of you that we are really thrilled to have you join us today. Whether you are turning in the from across the globe or at the next door, we appreciate you taking the time to be here. So today we will be diving into the international webinar on neurosurgery and spine surgery with some exclusive topics, and we are excited to share insight, ideas, and practical takeaways with you. So, uh, I I can remind you once again that use the chat box to ask questions, share your thoughts, and connect with others. We'll also have a dedicated question and answer session towards the end to address as many as which we can have doubts we can ask at last.
Shall I start my presentation?
Yeah, actually, the time has been your time has been over, but let me say that we'll wait for at least 5 minutes, and after that you can
Okay,
start.
all right, sounds good. Is
Thank
my
you.
voice is very good and clear?
Yeah, your
And
voice is,
can everyone see my screen? Can you see my screen?
yes, we can share your screen.
Okay, good.
Yes,
Thank you.
your screen and your voice is clear.
Thank you.
Welcome all the speakers, Dr. Gabriel Vargas and Dr. Bamak Darwono and Dr. Damian and Dr. Nicholas. All of you mostly and heartfully welcome to this webinar.
Thank you very much.
Thank you very much, Gary. So I'm glad to be part of this international meeting once more time. I think, as Dr. Timuchin said before, it's a big opportunity to share knowledge, share experience, and learn together one more time about the principal outcome of our patients about neurosurgery and spine surgery. So thank you very much. Let's go to enjoy the meeting.
I think 2 minutes. We can wait 2 more minutes and I will start my presentation.
Okay, before the presentation starts, I would like to request each and every speaker to uh, on their videos during the introduction time. Please.
Say that again.
Yeah, I'm saying that I'm requesting to all the doctors to keep their videos on while the introductions are going on.
Yeah, I think, Geet, shall I start? All right. Geet, do you hear me? Shall I start?
Yes, you can start.
Right. So,
I
good
request to the
afternoon.
first speaker, Dr. Bahadin, you can give your introduction and I would remind your topic that brain tumor surgery in the context of evolution in radiosurgery, neurosurgery, right?
Right. So good, I mean, depend on your time. It's good morning or good afternoon for everyone joining this webinar. This is a very, I mean, joyful meeting to learn from each other and to share our knowledge. And hopefully we can stay consistent with this meeting on a regular basis, and we can increase the number of these meetings by with years. So basically, my name is Bahadien Mohsen. I'm a consultant neurosurgeon. My practice currently in Saudi Arabia, Kingdom of Saudi Arabia. I just started my practice in Saudi Arabia over the last few months. I have a general, I would say, general neurosurgical practice alongside with a special interest in tumor surgery and skull-based surgeries. My topic today is brain tumor surgery in the context of evolution and radiosurgery. Through this presentation, I will review a personal case series highlighting some of the key outcomes and challenges encountered, and I will provide an insight about the new modern techniques in the brain tumor surgery, including minimally invasive approaches and intraoperative imaging and the advanced neuromonitoring. So for this, I have no disclosures. But by the way, this is today marks a special occasion in Saudi Arabia. This is the 94th National Day in Saudi Arabia since the unification of the kingdom in 1932 by the King Abdulaziz Al Saud. So like today is a very special occasion in Saudi Arabia. So it's a day of a national pride, reflecting the country's remarkable journey of growth, modernization, and contribution to the world. So this is a small case series. Again, I will provide like insight about rare pathologies in neurosurgical practice, and I will discuss the radiosurgery in the modern neurosurgical practice, including the techniques, advances, and the clinical outcomes. So brain tumors are a significant contributor to morbidity and mortality across the globe, including the Middle East. The complex nature of the brain tumors pathology, coupled with the late stage diagnosis in some regions, contributes to this high burden in the disease. However, with the advancement of the neurosurgical and oncological management, the outcomes we have a significant improvement in the survival rate and the quality of life for these patients. One of these is the minimally invasive approaches, including the endoscopic surgeries. We have the stereotactic, the gamma knife radiosurgery, and we have some, adjuvant therapy like the brachytherapy, waiver, and etc. This is I would say, the main modality, and we hear from time to time about viral oncologic therapy, immunotherapy, and the trials. My topic will be precise for the
Sorry, could you use presentation mode so we can see better your presentation, please? Presentation mode.
Go to the presentation mode. Shift. And let me see. Presentation mode. How can I do it? Needs any advice? Share.
I think you can see the.
Welcome to VoiceOver. VoiceOver speaks descriptions of items on the screen and can be used to control the computer using only your key.
This is something.
Sorry, I couldn't hear.
No.
That has changed a lot of things.
Sorry, I think if you go to the top of the screen on the icon play, maybe the screen will be large, full screen. Yes, it's in the middle. No, play. Just on the icon. Play. It's in the middle. You see you share, comment, media, shape, text, chart, table, and play.
Is it on the Zoom meeting itself, or
No,
is it
it's
on
in your presentation, in your slides, there would be an icon that say that is a screen or something like that. It's a.
I know how to do it on the
Or you can
this is
you can continue like that.
April.
You can continue like this.
Yep,
But
okay, right.
But I think that you can.
I will just continue. I try to make it bigger, probably this a little bit big. think this is big enough. I mean, everyone, I would say, can see.
Okay.
So,
Okay.
I'm like doing my best to
Minute, please. I can see that if we tap on the presentation, then we can see it bigger, isn't it?
if I double click on the presentation itself,
Yeah,
I mean, if I make a play, oh, here you go. Here you go. Is that better?
yes.
Excellent, Nat.
Yeah.
Like
Now it's excellent. Congratulations.
All right.
I'm sorry for disturbing
Very
you.
good. Okay, congrats.
It's all right. So let's go back to the presentation. So one of these modalities are, as we say, the minimally invasive approaches, including the endoscopic approaches and the gamma knife radiosurgery and the adjuvant therapy like brachytherapy and the waivers. We hear from time to time the chemotherapeutic trials that comes up with with a significant functional outcome and survival. And everyone knows that immunotherapy and the viral oncolytic therapy are ongoing as well for brain tumors. One of the minimally invasive modality that it's increasing right now, it's the gamma knife radiosurgery. This is a minimally invasive approach. This is a very minimally invasive approach and a same-day procedure that can treat some types of brain tumors. It's usually for the small, deep-seated lesion. I will give more information in the upcoming slides. So the gamma knife, again, it's a focused radiation. It can be utilized in brain metastasis, meningioma, schwannomas, and others. As an upfront standalone management or as an adjuvant therapy after or before surgery in some cases. But the patient selection is very important in these cases. So the gamma knife, it's increasing worldwide right now. The treatment is widely used for hazardous place due to the risk after treatment. As you can see, we can see here a gamma knife radiosurgery that being utilized for treating a posterior fossa metastasis with a compression on the fourth ventricle. And this published paper, I was part of the teamwork. It was, I mean, it was, it was, I would say, a landmark paper that give an explanation what happened to the perilegional edema after giving the gamma knife radiosurgery. Dispels the myth of increase in the edema and the risk of brain herniation with gamma knife in the posterior fossa surgery. In this diagram, you can see what happened to the edema after treating a posterior fossa metastasis with a gamma knife radiosurgery. So this is one of the application of the gamma knife where in a place that was prohibited or not favored for a gamma knife in the posterior fossa. Again, can we apply the gamma knife for every brain metastasis in the posterior fossa? The short answer is no. As in this case, as you can see, this is a young lady that came to my practice. By the way, I shared the cases that I did surgically. This is a young lady with a solitary metastasis and the triple negative breast metastasis, which pose a good survival, good survival rates. So the patient was symptomatic from this lesion and it was solitary and systemic disease was very stable. So, and as you can see on the coronal image and the sagittal image, it was like the tonsils was standing at the foramen magnum. So I took this tumor out surgically. I did not use the gamma knife, despite the fact I believe in its effect in the posterior fossa metastasis. So the gray zone, it's still, we cannot standardize it for every brain metastasis to do a gamma knife. All right. This is another case that I did surgically. Instead of a gamma knife radiosurgery for a brain metastasis. As you can see, it was a solitary met again. It was badly symptomatic. You can see the effacement of the central sulcus and the edema in the motor strip. So I favor to do a surgical resection to address the symptoms. And since the patient has a very good, very good functional state, I took this patient surgically. Again, if this patient with metastasis has a let's say a progression in the systemic disease, I will, I mean, and the expected life is very short. I can use the gamma knife radiosurgery to treat this brain metastasis. This is one of the nice cases that came to my practice with a huge brain metastasis, and it turns to be a sarcoma that rises from the thigh and came to the brain. The patient was very badly symptomatic and like in a brain herniation status. So you cannot apply any radiotherapy or any gamma knife for this a huge brain metastasis. By the way, the term big in the brain metastasis, it goes for brain metastasis with a maximum diameter more than 2 centimeters. After I took this patient to the OR, I mean, the patient has survived, as I remember, for at least 24 months. I follow up on him with a good functional outcome. I mean, for a very malignant tumor, as everyone knows, the soft tissue sarcoma are malignant. It's very rare. It's about less than 1% of all adult malignant tumors. And it tends to be a metastatic myxoid liposarcoma, like from the thigh. It went to the brain directly, like there is no other metastasis in his body. But later on, he started to have other metastases in other side of the body. So again, the technique of trying to do an any block resection, with taking out the abnormal, even the abnormal bone. This is one of the, I mean, one of the techniques that I learned, trying to maximize this resection and decrease the rate of the recurrence. Again, going back now, I will switch my talk to the other type of brain tumor, other than the brain metastasis. I will switch my talk to the meningiomas. Does the gamma knife can be used in meningiomas? Yes, it's applicable either for a convexity or for a skull base. So usually it's used for a small size. Well, let's say we have an elderly patient with a growing small meningioma. You can still use the gamma knife radiosurgery as a treatment modality, as an upfront option for if the lesion is growing and asymptomatic, and the patient is an elderly and having, I would say, very high risk for surgery. So it's still applicable with a reasonable, I would say, outcome, and a very low chance of toxicity from the radiation, as some people say. This is a paper that we published about the safety for the gamma knife radiosurgery for a small skull-base meningioma that has a close proximity with the optic apparatus or the optic nerve. And the technique was utilized. It's the fractionation of the gamma knife. Instead of giving the radiation over one session, we fractionated for 4 or 5 sessions. And thereby we decrease the chances of toxicity to nearby structure. So this is one of the paper that we published together during my fellowship time. And like we follow up patient up to 2 years without any signs of toxicity on the nearby structure, either the brain or the optic nerve or the I would say the optic apparatus. Do we can use the gamma knife for every skull-base meningioma? In this case, I had this plenum sphenoidal meningioma. This is one of my cases that I did. The patient came to my practice with a decreased vision and optic canal invasion of this. You cannot apply the gamma knife for every patient. As you can see, I use the technique of retractor. We call it retractor-less. I don't use retractors during my resections. So this is a retractor-less brain tumor resection for the skull-base tumor. I think this technique is adopted by many neurosurgeons. You can see the infiltration of the intraorbital part of the tumor was totally resected with my surgery. And the patient gained a very good outcome, from the visual field perspective. This is again in the cases where the gamma knife radiosurgery we cannot apply it for the meningioma, even in the skull base. This is sphenoorbital meningioma, and everyone know that the sphenoorbital meningioma, I mean, it's quite infrequent, and you cannot, I would say, apply a gamma knife radiosurgery to treat this tumor. So I just took the patient to the OR and I resect this tumor. Again, so we speak about the upfront use of the gamma knife as a treatment modality in the skull-based meningioma. And we speak about the surgical resection of the skull-based meningiomas as well. And now I will speak about the using of gamma knife as an adjuvant therapy. As you can see in this patient, he has a huge, massive meningioma in the skull base with invasion to the would say to the cerebrovascular structure in the skull base. And what I did basically, I just took the patient to the OR. I resected the tumor, and I left some residual which has been treated with the gamma knife radiosurgery. So in the skull-based meningioma, either we can apply the gamma knife radiosurgery as a standalone option, or we can use it, or we can go just for a surgical resection, or we can use it an adjuvant after we do the surgical resection. I mean, chasing a small residual in the cavernous sign, sometimes it might be challenging, or if you have a piece stick to the arteries. So gamma knife is I would say is a reasonable option after surgical resection for tumors. The discussion in the meetings always, shall we go immediately for a gamma knife after tumor resection, or shall we wait? I would say the short answer for this is, I mean, depends on the grade of the meningioma. In my practice, if it tends to be a grade 1 meningioma, I observe it. And if it has been grown, I will refer to a gamma knife radiosurgery. Or if it tends to be a grade 2 meningioma, I refer them immediately to the gamma knife radiosurgery after treatment. By the way, this patient, after 4-month follow-up for this huge, massive, I mean, big mother tumor in his skull base, and he's like, as you can see, has a very good outcome after his surgery. You can see like nothing from the facial nerve. I would say, despite being a skull base, his facial nerve is very intact. And as you can see in his background, this is Jerash in Jordan. This was inhabited like 5,000 years before Christ. And it's a old Greco-Roman settlement. It's very nice place to visit. I will move for the next case. This is a case of a very, I would say, like this is the cases that we don't show in our practice. This is an in-plaque recurrent meningioma. You know how the in-plaque meningiomas are very infiltrative. I think it was a grade 2 meningioma. So when the patient came to my practice, he has already 2 surgery done for his meningioma, and he has a radiotherapy. And when he came to my practice, he came with a decreased vision. As you can see, there is a compression on the optic nerve and the optic apparatus in the first row of the images. And I asked myself, shall I mean, go to this risky surgery with high chances of infection and I mean complication, since it will be this 3rd surgery. So I decided, I mean, I took the patient to the OR and I did a 3rd resection for this malignant tumor, the meningioma. And as you can see, there is a quite significant decompression around the optic nerve and the optic apparatus, as I show in the cases. This is how in the first image you can see how, I mean, like the scalp is very thin and the bone color was, I would say, this is like after radiation and 3rd surgery. It was, I mean, very, it was like very, so I have, if you see, like I have, so I just did a immediate cranioplasty with what I have. And on the 3rd picture for this particular case, we monitor the abducent nerve. I mean, for the cavernous sinus part of the tumor, like, I mean, just to make sure that we don't hurt his abducent nerve, not to have a double vision. And this is like one of the, I mean, discussion point that we should speak if someone do this like type of neuromonitoring in his cases. This is, I will skip this slide. For this is another paper that my comes on the after I finish I'm done with the meningiomas. I will speak about the schwannomas right now. This is an international multi-center study about the utilizing of the gamma knife radiosurgery for trigeminal schwannomas. I mean, despite being a skull-based surgeon, again, it's still like this is like a 10 years follow-up with a very good functional, I mean, very good local control. Like I think like 80% of the patient have a very good local control. So I think the discussion about the gamma knife, it's a feasible. We should believe in it. It's utilized. It's very important in our practice that we should consider, but not to applying this technology for every single case. I mean, Walter Dandy, I think one of the pioneers in neurosurgery. This is the picture from one of his book in the 1966. I mean, his techniques was very good and was applicable, but I mean, with time, we should change our practice. What was acceptable like 50 years ago is right now has been changed. So, I mean, the point is just trying to learn and to keep up to date with the updated techniques in neurosurgery. This is, I mean, one of the patients that I offered gamma knife myself for the patient. She told me, doctor, after discussion with her about all the modality, I prefer to do a surgery. So I just like, I went for a Simpson grade 0 resection. I removed the tumor, I put a new bone graft, and I just took it out. Despite she is a good candidate for a gamma knife radiosurgery, but I think she was young and she was scared. She read a lot, and probably someone scared her, and she decided to go for a surgical resection, given the young age. She was, I think, like in her 30s, like early 30s. So again, it's a feasible, it's debatable, but we should have a very good selection of the patient. This patient come to my practice 5 years with this brain tumor not being touched. As has been told, he has like a multiple, I think 5 or 6 comorbidities, stents, asthmatic, a coronary artery disease, peripheral artery disease with this massive, as everyone see, the massive brain tumor. Like no one, I mean, offered surgery giving the risk of this, like, I mean, surgery and the risky patients. So I just took the patient to the OR and I just resect what I believe it's maximally effective for him. And I alleviate his weakness. He has improved in his weakness after surgery. And he was on 3 anti-epileptic. I mean, I think after like 6 months, I left him with one anti-epileptic medication with a single instead of 3 with a minimum dose. This is one of the paper that speaking about the safety of craniotomy, even in the octogenarian. So the age doesn't need to challenge us when we make decision for the resection of these tumors. This is one of the cases that came to my practice just recently, like a month ago. He came with pituitary apoplexy. As everyone knows, this is an emergency. And one of my point of sharing this tumor to emphasize the fact of the four hands technique, which it's done by, I mean, the four hands technique. It's endoscopic endonasal approach. It's a joint case between me and my ENT consultant colleague. So we did this case together with the most, I would say, the most modern technique in the pituitary, which is the four hands technique. I know that some people still do either transcranial or, I mean, microscopic surgery for this for this particular tumor. But like from what I have learned during my fellowship, we did it with my ENT consultant as a joint case with endoscopic intranasal technique. I want to like put it just to see what is the insights from my colleagues about this case. This is the navigation system, and this is the endoscopic picture in my place. This is one of my recent patient as well. I mean, it's related a little bit to skull base and oncology. as you can see, there is a basilar invagination and the brainstem compression. He came to me unconscious, like GCS10, with sepsis, and you can see, and difficulty swallowing. He has like almost lower cranial nerve palsy. So, like I ask myself, shall I go from the front or from the back for this tumor? And I mean, he has like a nasopharyngeal carcinoma treated with surgery, and he has a local infection. And this is a C1, C2 infection case. So I asked myself, shall I go from the front or from the back? I went from the back, and I was able to do an ossifusion for this patient and decompression on the foramen magnum. And I achieved a good decompression, as everyone see on this screen. This is I will conclude my presentation with this case that I did. I mean, the patient, I haven't seen him. I did him like last week. This is a huge spinal chordoma, and everyone know that the spinal chordoma, if you aim for an excisional resection, like gross total resection, your patient will like come out with sexual dysfunction, incontinence, and weakness in his leg. So I was able to achieve a resection of around, I would say, 70% of the tumor. I left some residual where like the cranial nerves was like, and luckily in Saudi Arabia, we have the proton beam therapy present in Riyadh. So for the chordomas, I would say we have in Saudi Arabia and Riyadh specifically, we have the proton beam therapy, which will help the chordoma patient in our practices. I would say thank you for everyone who was listening, and I will be ready to take the questions after. I mean, I don't know if Geets is planning to keep the question for the end of the presentation or to open the to open the podium right now. Thank you everyone for listening. I would love to hear your feedback and your comment about about the topic. Thank you so much. Geets?
Yes. Thank you, doctor. Thank you for your beautiful presentation.
Good presentation. Congratulations.
Thank you, sir.
Nice picture also of your country. I visit Jerash 2 years ago. Very nice place and lovely place, actually, Jordan. And talking about your presentation, um, depending of the availability of the techniques, of course, if you have gamma knife, proton beam, all the things that I don't have here in my city, proton beam, for example, I don't have. Radiosurgery, yes, but not in my hospital. So I think that neurosurgery today, sometimes depending of the place of work, and we as a neurosurgeons needs to develop, of course, um, our practice depending on that. And I think that for some tumors, for sure, you need to do radiosurgery instead of brain surgery. I am an old surgeon, so I try to operate maybe most of my cases, not using radiosurgery for something that maybe I can, give the people. So my question for you is, how do you decide to do a surgery knowing that you have all of technology, radiosurgery with the gamma knife, with proton beam, and you have a tumor that maybe you can take out as you did, but what is your way to decide what to do?
I mean, again, this is a very gray zone of it's a gray zone. I always offer in my clinic all the treatment option for the patient, and I make the patient decide. I tell him about, I mean, even the gamma knife, the toxicity, the side effect of the toxicity, the risk of malignancy changing. I mean, I give all the, I mean, the treatment modality with its adverse effect, and I keep the decision come from the patient. To me, honestly speaking, I prefer to do surgical resection for all of my patients. But I mean, that will, I mean, from every perspective, I always joy to go to the surgery. It will, I mean, it will, I think it will, I will get more revenues. I will get paid more if I do more surgeries. But always, I mean, I have the aim of excellence in the patient care. This is my point of view. I mean, I make my patient decide. I give him all the option. To me, honestly speaking, I prefer to go to the surgery for every single brain tumor because I have the joy doing it. But from the, I mean, from the patient care or patient excellence standpoint, I just like let my patient know about the technology and decide if there's a other treatment modality for him. All right, this is how this is what is my insight. So just like to let him know about the modality, but I would say I prefer certainly to go to the OR to do all my cases. And it's very helpful in the residual. I mean, all of us have done some surgery. Sometimes you leave a residual. It's very helpful to be aware of it, to, I mean, to send it instead of doing a redo surgery for a 1 centi or 2 centi residual tumor, just to offer I mean, to offer radiation therapy or a gamma knife radiosurgery. So this is my just philosophy behind it. Thank you for your question. I hope I answered.
Yeah, that's really good. So I would ask to Dr. Damian and Dr. Bambang or some other doctors, is there any interested discussions on this topic anymore?
Yes, of course.
Please.
Thank you, Anjali. So first of all, congratulations to Dr. Mushen for this amazing presentation. Wonderful cases, wonderful pictures. So my question for you, sorry, allow me to introduce myself. I'm Dr. Damian, consultant neurosurgeon from Cuba. I'm currently working in Banjul, Gambia. So in Havana, Cuba, we have experience performing radiotherapy for neuro-oncology patients. We see some patients who develop radionecrosis. We identified this kind of complication with performing a SPECT-CT. So my question for you, doctor, is if you know the incidence of radionecrosis in your center and how you identify this complication.
Yes, a very good question. So the percentage of radiation necrosis is 10 to 15% in all literature. You cannot deny it. It could happen. It's either once it's happened, it's either symptomatic or asymptomatic, depends on the situation. So there is some techniques like the conformality of the treatment, etc., that you minimize the radiation, the fractionation that I speak about. It will minimize your radiation there. So there is some techniques that helps you to decrease the percent of radiation necrosis. This is first. And the second, if it's happened, again, if it's symptomatic or asymptomatic, sometimes we treat them with the bevacizumab, the Avastin, and sometimes, and I would say that I was learned about the laser interstitial thermal therapy. I mean, the LIT, this is one of the new modality in neuro-oncology. I mean, I've trained, I don't have it right now in my place, but we use the LIT for these cases. And the steroids, this is the treatment modality, and some people use the hyperbaric oxygen therapy for these radiation necrosis. So more importantly is to improve the techniques. If you find that the rate of radiation necrosis is above 20%, there is something wrong. I mean, it happens, and even if it happens, you should just make sure, I mean, if it's symptomatic, you can just give some steroids and that will improve with time. Sometimes we use the Avastin and bevacizumab. MRI perfusion as well is a good modality of treatment. And sometimes in very rare cases, you just stick a needle, you do a very guide biopsy for this and send it for the lab. And this will can differentiate between a tumor recurrence versus a radiation necrosis in the treated area. All right? Did that answer
Yeah.
the question?
Thank you very much. I think that answered my question. Congratulations once more time. Was a
Thank you.
wonderful presentation. Thank you very much.
Thank you very much, Doctor. Shall we go for second presentation or I think second presentation need to be given by Dr. Gabriel. Yeah, hello, Dr. Gabriel. Are you there? Yeah, hello, Dr. Gabriel. Are you
Probably she's
there?
muted.
When I
Yeah, hello, Doctor. How are you? Nice to meet you.
I mean,
Could
give
you
him a
yourself?
he's muted. Just let him know that he's muted.
Dr. Gabriel, can you unmute yourself?
okay. Hello. You hear me? Yes.
Yeah, we can hear you. Yeah, please
And did you
continue.
see my presentation? Yes. Did you see my presentation? Okay or not?
Yes.
Yes, doctor, we can see your presentation.
Of course, we can see your presentation.
Okay.
I
So
request you to
I'm
do introduction so that within 1 minute we can start your presentation. So
okay.
I would like to introduce Dr. Gabriel Manuel. Please continue.
Okay, I'm Gabriel Vargas Grau. I'm from Bucaramanga, Colombia. It's the fifth city in Colombia. Thank you for inviting me to share my cases and my experience in brain tumors. My place is not with all the technology, but we try to develop some things that I want to share with you. I work on the University of Santander, which is and in two clinics right now, University Hospital Comuneros and Clínica Chicamocha. And I want to present to you some development of brain tumor surgery in limited resources play and some cases about how I did during 32 years of practice right now, and of course see some comments. I use today name that we call functional preventive neuro-oncology, and tried, of course, to do a maximal safe resection as for example, Dr. Dufault teach to us, and I was with him and learned from him many things that today changed my practice. I started in 1993 my practice, and I started in 1996 the neuroendoscopic approaches for cranial surgery. And in 1998, I took with Dr. Joe, who developed the endoscopic endonasal approach, at that time, practical courses with cadavers. So since 1998, I started my practice for all pituitary tumors. In fact, it was the first case in Colombia to do that practice. And in 2005, I learned from Dr. Berger and Dr. Dufault the practice of awake craniotomy. And in 2009, we started with neuronavigation and the use of 5LA. In fact, the first case in Latin America was done here in Bucaramanga, in my place. And in 2017, starting in Colombia, things with the health care. So in my clinic, they say you should stop to use neuronavigation. It's too expensive. In some hospitals in Colombia, you need to rent the navigation system. So I started doing ultrasound surgery, ultrasound diagnostic use. So the main topic of my talk is about how I use these techniques and trying to do the maximal safe resection, as I told you. As a neurosurgeons, we need to always keep in mind that we need to not harm the patient. And by prevention, I mean the act of stopping something from happening. So try to stop the tumor from killing or injure the patient. But as a neurosurgeon, we need to know when to stop, when to just keep that little tumor there, because I call the last little bit moment, no? When we are in surgery and maybe there is a piece attached to the vessel or the nerve, but we want to take this part, and the decision of when to stop is one of the things that we suffer many times. We have most of the times as a neurosurgeons, good cases, always good cases. But one case remind us that we're not God. We need to maybe keep that piece for radiosurgery or things like that. So the decision of how to take the whole tumor or maybe leave a little piece for other technique is something that today we need to do. Of course, we need to follow the ideas of the masters, Al-Mefti, Sami, all of those big masters with 5,000, 8,000 cases. And of course, we need to learn how to do it, but so it's not easy. Neurosurgery is something not easy. I love this work of Hippocrates that says intentional harm, maleficency, and harm from lack of knowledge or training. This is something really important today in neurosurgery. We have a lot of exposure to many talks, to many people telling something. And one of the things that we cannot do is to try to do something that we see in a conference and just go and do it. This, many times, I change things from tips from the people. And this is okay if you have the experience to change something. But for example, if I am doing microsurgery and I see somebody doing endoscopy, just try to do this just because I saw on the conference. This is not good knowledge and good training. So this is one advice that I want to do. I have this experience in the recollect data from 10 years of practice. This is the main tumors that I treat during the years, mostly meningiomas, pituitary tumors, and many intraaxial tumors, low-grade and high-grade tumors. So we need to remind that the volume of resection is important. But for example, we heard from Andy Anderson that we need to take at least 98% of the tumors, which is many times is impossible. And you can improve the patients if you resect at least 70% of the tumor. Less than that is similar to biopsy, but at least 70% is okay. And also with the residual volume, if you leave less than 5 centimeters cubics, it's okay for the patient, and that's impact on the overall survival, the progression-free survival. We have a lot of pathology, and of course we know that with the age, the older the patient, the difficult the situation for the patient. I see in this diagram how many techniques we have available. The main techniques today for me is to try to do awake craniotomy in most of the patients, intraaxial tumors. I try to do it in all, with brain mapping, with cortical monitoring, with subcortical monitoring. And of course, it's good to have intraoperative imaging with CT, MRI, intraoperative MRI, of course. But the technique that I use right now is intraoperative ultrasound. And of course, this neurosurgeon needs to have a good team in order to practice. And 5LA is one of the things that were developed for brain tumor, intraaxial brain tumor. Very good technique. I use it. I started using right now. I don't have the possibility because I moved the hospital. For low-grade and high-grade gliomas, of course, the purpose of the surgery should be radical resection. And this radical resection impact on the progression-free survival, on the overall survival. And of course, we need to keep in mind the quality of life of that patients. And I have 2 or 3 main things in mind. How is the patient, the quality of life, the occupation? We try to know about the patient a lot. Of course, the experience of the surgeon, the technique we can see here, Dr. Dufault, and it's not the same than me or other colleagues. These colleagues are from Italy. And of course, we need to recognize what are our limits. And of course, as I told before, the place where we work. If I have all the technology, I need to use it, of course. In craniotomy, to do a single awake patient all the time. It's not easy. Convince our anesthesiologists to do awake sleep. So we try to keep the patients awake all the time. Sometimes we have some nausea, vomiting, seizures, and we know how to manage those kind of problems. Of course, not always is good, and I want to advise this. Many times we worsen the motor deficit at the beginning, and this is not wrong if you preserve the tracts. This is very important. When I start in 2005 and 2009, cortical mapping and all things, I have many colleagues watching me and telling me or telling the directors, this guy is doing experimental surgery and he was doing awake craniotomy monitoring, and the patient works after the surgery. And of course, this happened. We need to know that. But if you preserve the tracts, the patient is going to improve. So this is one important thing. The goals, of course, of awake surgery is to do a complete resection. We use most of the time bipolar stimulation, but many colleagues use monopolar in order to stimulate more deep areas. So it depends of your technique, and of course you can use this place in order to use electrocorticography during the surgery. I invite Dr. Dufault to my place, and I did this poster. And right now he showed this poster to say, this is wrong in order to say that every single cortical place is with some function. You need to do an stimulation and to know in each patient where is the language, where is the tracks, and try to really know exactly where are the functions of the patient. And the only way to do it is not with tractography or functional MRI, is inside the operating room. And of course, we are learning from him these tracks and this connection, and we need to pay attention of all functions with neuropsychological evaluation, pre and post, or intraoperative and postoperative. And we prepare many things. For example, this single tip. If the patient is using lens, we cut one of the legs in order to put the lens for the patient, and then do the incision without problem. This is something we use multitasking evaluation. Here we have an engineering during the surgery using the computer, some people nighting, another surgeon using the forceps for surgery during all the time. And of course, we use navigation, tractography, all the information, and try to figure out where are the exact functional areas of the patient, and try to remove as much as we can. For example, in this case, we know many things from the patient, and we try to use this multitasking evaluation at the same time, moving and talking and evaluating the patient most of the time, and of course detect where are the function. And we want to do this kind of resection, very huge resections, in block resections, sulcus to sulcus, is possible, and try to limit the areas of the patient in order to do a big resection, even in eloquent areas. For that, we trained people. This is Dr. Valerio from Miami, teaching us how to start navigation in 2009. We did a course for Latin American neurosurgeons, and not talking about intraxial tumors, but we have with my son right now, I have two sons, neurosurgeons, one neurosurgeon, one resident, and we are doing right now neuronavigation, pituitary surgery. But right now, we are working on this removal of medial wall of cavernous sinus in order to try to cure many patients from, for example, functional tumors in the pituitary. We just start this year with that technique that my son learned from Dr. Garner in Pittsburgh. We have real time and virtual, sorry for the Spanish slide, tools for surgery in real time are the awake craniotomy, the neural monitoring, the ultrasound, the 5LA, that all are real-time tools during the surgery. Navigation is a virtual time, as you know, of course. Some words about ultrasound. We use this. We use a gynecologist transducer. We don't have this very nice BK ultrasound tips, very expensive for us. We use just some techniques that we learn from radiologists. And the ultrasound for us is one of the best tools ever have, cost effective. We can use quick and easy, very nice. And we just borrow from the gynecologist people and use this intracavitary tool. And we did some courses with radiologists trying to learn about ultrasound. I want to share these images. This is MRI. This is ultrasound. We can really see very nice, even with this. This is not a BK, this is just this. And of course, try to do many resections. So we combine awake craniotomy, ultrasound all the time, most of the time. Case number 2, of course, this metastasis patient. We use awake craniotomy, ultrasound in order to take this tumor out of one other case. Similar images. This is something that we want to share with you also. This is a speculum, nasal speculum that we use as a technique of dilators that you have seen in many cases. In most of the cases, we are using bipolar stimulation, patient awake, and we do the surgery during most of the time. We use many times bipolar with 3 milliamps, 4 milliamps, and that's it. We don't like to use, at the beginning, we use 10 milliamps, 15 milliamps, but this increase the possibility of seizures. Some words about 5LA. Many people use yellow fluorescence, which is good. It's very cheap and it's good, of course, but this is nothing to do with 5LA. 5LA was developed for Dr. Stummer, and you know that this really inside of many high-grade tumors and transform the exogenous 5LA in fluorescent molecule that is in a red way. So you can see here how was developed the fluorescence. The studies from the European approval in order to do that. The 5LA was a tool that in my mind is something that if you have available, you need to use it in every single case. It's very amazing. You know that for the FDA approval, they never approve as a as a medication. They approve in the FDA as a visualization, optic visualization for brain tumors, not as a medication. So if you have the possibility to use 5, this is one of the tools that we really need to apply. For example, in this study from Dr. Wolfeger, you can see in low-grade gliomas how you can see small pieces of high-grade gliomas within the low-grade glioma. In a meta-analysis in 22 series with 1,000 patients, the sensibility was great for high-grade gliomas, meningiomas, specificity for meningiomas, metastases. So today, 5LA is used in high-grade, low-grade metastasis, gliomas. Many times you can see the fluorescence, other times not. In Colombia and Latin America, we were the first to use 5LA. It was approved in my country as a vital drug, not available. This is the certificate that I obtained in Europe in a course. And we started using this 5LA. You can see here the fluorescence. So it's a good, if you have navigation, but of course, if you have fluorescence, you can see the limit of the tumor in a very good way. So you have the confidence to use it as a good tool for visualization. This is some of our cases using 5LA. This big tumor after the removal with 5LA, preoperative, postoperative case. These other tools, preoperative, postoperative, big case, preoperative, postoperative. We leave some tumors aside, combination, of course, with awake craniotomies, as we can see. I want to advance because the time is, this is preoperative, postoperative. So we present this in the last work course in South Africa, our experience in awake craniotomy, ultrasound. And in conclusion, we need to know that the awake craniotomy, intraoperative ultrasound, and 5LA are important tools for intraaxial tumor resection in the real-time image and monitoring, have great impact in resection and progression-free survival. Of course, you need a learning curve, proper training, ultrasound cost-effective, and the quality of life is the main thing that we need to preserve on the patients. And the brain tumors needs, of course, individual approach. We invite you to our 14th International Brain Tumor Awareness Day Symposium, which will be in November 2 for free. I can share the link for this tumor. We are going to have Dr. Sujit Prabhu from MD Anderson, a talk from Dr. Dufo, and some Latin American neurosurgeons. So I hope that you can be with us. This is my family, my two sons, neurosurgeon and resident of neurosurgeon. And that's it. Thank you very much. Thank you very much.
A very nice presentation. Thank you so much for the beautiful cases that you show. I have a few questions regarding your awake techniques. So do you pin the patient and fix the Mayfield with the head, or you just keep the head? I mean, without fixing it to the table itself. And what do you do for the intraoperative seizure once it's happened? What is your techniques to deal with the intraoperative seizure that you do? And do you apply DTI? No, Defoe is not a friend with the DTIs, the tractography, but do you apply the DTI? I saw some slides that you do a DTI for these cases. First question.
Yes. Quick answer. At first, yes, I fix the patient all the time. All the time I apply it on the Mayfield. I just, I don't do a block hardware, just block the pins. That's it. I learned from Dr. Dufo. Not only the places where I'm going to apply the pins, I just block that. That's enough. And I, of course, always fix the patient. Second, the use of tractography is, yes, is good because you have an idea where are the tracks, but you cannot rely only on the tractography. You need to look for the track during the surgery. There is no other way to know where is the place. And third, the management of the seizures. Of course, we have always a cold Ringer lactate in our operating table, and we just wash the brain with that, and most of the time that is enough for control the seizure. Sometimes I use a little bit of midazolam, but we don't want to do that because the patient kept sleep and you lose the monitoring. So we try to use only cold Ringer, and that most of the time is enough.
Does anyone else have a question? So until someone come up with a question. So I saw the speculum, the hard speculum that you use. This is, I mean, very interesting to see. I'm sure that you are aware about the brain path and the Vicar. I would say it's the same techniques, but I like the idea of the speculum. It's like more dynamic.
I lose
Yes.
a little bit your sound, so I don't hear very well. What do you think?
So about using the speculum, you are aware of the brain path, right? And the Vicar system instead of the speculum, it's more system of
Of
tube
course,
dilators. I'm sure that you are aware
of
of it, but
course,
I just like want to.
of course, of course.
I
I
think
just
it's just like. Yep.
Yeah, of course. We use when we have available, of course, we use dilators and everything and the kit for that. But if we don't have that, I use just speculum. Just I want to show you how to solve problems when you don't have the tools that we need to use.
Any other question from the speakers, or shall we move to the next presentation? Geets?
Yes, I have a question. Thank you very much. So, Professor Vargas, first of all, congratulations for this amazing presentation. Particularly, I'm learning a lot today. So, my question for you is a simple question. I saw many times when we use intraoperative ultrasound. Uh, Normally, we use the guiding transducer, and always we cover the transducer with a surgical glove, but we use a little bit of normal saline or radial lactate inside to increase the definition of the image. So it's more than an advice. Any advice about another kind of substance that we can use to improve this technique?
Yes, if you use the glove, this is too thick. Don't use the glove. Use the laparoscopic plastic. So we cover, first, we apply the gel on the transducer first, and then with care, we advance the transducer. Cover with the plastic laparoscopic bag, and then you should be sure that you don't have air inside, very tight. And then after the craniotomy, we apply chlorhexidine soap before open the dura, because this is toxic for the cortical area. So before open the dura, we apply the soap. Then we use a little heart moving, around, try to localize the tumor and see what is the limits. After that, we wash that soap, open the dura, and then we're just using the saline and everything. But at the beginning, we can have a very nice view, as you see there, over the dura with soap, chlorhexidine soap.
Wow, thank you very much, Professor. Congratulations one more time.
think we can move to the next presentation. I am not sharing the screen, yes? I stopped sharing the screen.
Hello, yes, I'm the next. I'm the next. I will try to share my my presentation. Let's see. Can you see it?
Yes, we can
Yes.
see it. Perfect.
Yes.
Yes.
Okay. Well, I'm Dr. Fernando Muñoz Hernández. I'm from Barcelona, Spain. I'm the chief of the neurosurgical department of Hospital de Sant Pau, Hospital del Mar. And I will talk to you about the posterior fossa approaches for challenging cases. As I said, I live in Barcelona, in this beautiful city, very close to this monument, Sagrada Familia. The two public hospitals where I work is this one, Hospital de Sant Pau, and this is the old hospital that it's very close to the new one. It's a modernist jewel of art, so I will recommend you to come and to see the old hospital. It's incredible, very close to the Sagrada Familia. And the other hospital that I work is Hospital del Mar, very close to the sea, an amazing view of the sea. So if you come, you can send me an email and I will show you. Well, my area of expertise is school-based. I have been taught by a lot of surgeons, not only in Barcelona. I have traveled around the world trying to know the school-based surgery from the best. I consider from the best. So, well, it's a long training and I'm still learning, but well, it's my passion. The index of the presentation will be this. We will make a short anatomic review. Well, you know there are three fossas in the school base, and we will talk about this posterior fossa, this difficult posterior fossa, where we have some bones that we have to take into account. The occipital bone, the clivus, very important, the petrous, the temporal bone with the petrous bone, and their grooves, their holes where some cranial nerves passes through. So very important anatomy. We should be master in this anatomy. About the Roton, describe three neurovascular complex when we are talking about posterior fossa and cerebellopontine angle. This superior part that is formed by tentorial cerebral surface, cerebellomesencephalic cistern. We can find the third, fourth, and fifth, and the superior cerebellar artery. There is the middle part of the cerebellopontine angle, where we can find the petrosal cerebellar surface, cerebellopontine cistern. We can find the 6, 7, and 8, and we find the anterior-inferior cerebellar artery. And the inferior part of the cerebellopontine angle, the suboccipital cerebellar surface, with the cerebellomedullary cistern, where we release CSF when we are performing the retrosegmental approach, and we can find the 9, 10, 11, and 12, and the vertebral artery and the pica. This is the frontal view of the content of this posterior fossa. and the two vertebral arteries, this junction with to form the basilar artery, the two ICAs, SCAs, and posterior cerebellar arteries, the importance of the venous anatomy, and the birth of the cranial nerves. The cranial nerves, very important to know where they are exactly. Which approaches do we use to arrive to the lesions? One, the external approaches, the craniotomy or craniectomy approaches, we can use the orbitozygomatic approach. This is only for the superior part of the posterior fossa. The subtemporal approach, we can arrive to the 2/3 superior of the clivus, of this part of the posterior fossa. The petrosal approach under variants, we can reach all this cerebropontine angle, as we can use the workhorse approach, that is retrosigmoid. And if we want to arrive to the inferior third of the clivus, you have to use the suboccipital far lateral approach to arrive this region. We can't forget the endoscopic endonasal approach for these lesions that are in the middle of the clivus, and we will talk a little bit more later. These are our main choices: the anterior and/or posterior petrosectomy, the retrosigmoid, and the endoscopic endonasal. This subtemporal anterior transpetrosal approach, this is you can see the anatomic vision of this approach, where we perform peeling of the middle fossa to see the trigeminal nerve, the GSPN, and this part, that is the Kawase approach, you can drill it to get access to the posterior fossa. Very important, because if we open widely the tentorium, we can reach this part of the anterolateral part of the bones, and you can get access to this region. And if we put the endoscope, we can see that we can arrive to decompress the trigeminal nerve. This is the 7 and 8, 6 nerve are even we can almost reach the lower cranial nerves. So this is a great approach for the middle and superior part of the clivus. There is a variation that is called mi plata, that it was described by my friend Jorge Mura, and this variation includes the releasing the nerves and cutting well the tentorium, and to have a big access to this supratentoral and infratentoral region, and even to getting access to the cavernous sinus. It would be indicated for median and big tumors with supra and infratentorial extension, and for me the limit is the internal auditory canal 7 and 8, but maybe with the use of endoscope we can reach inferior to these structures. Transpetrosal approach, there are some variants, transcochlear, that we drill all the petrous bone. The translabyrinth approach, but these two approaches we lose hearing, and the retrolabyrinthine approach. We can combine it with the anterior petrosal. This would be the image. After opening the tentorium, we can reach all this part, the inferior, middle, and superior part of the clivus, and even the supratentorial part. And this would be the image. So For me, it's indicator for medium and big tumors of the region with suprainfratemporal extension and the limits anterior, the external auditory canal and facial nerve. But we try not to move this facial nerve because the facial paralysis would be almost for sure. And posterior the sigmoid sinus, and just to be careful with the jugular gulf. If we have high jugular gulf, this region is difficult to reach. The retrosigmoid approach is the workhorse. Through this approach, we can arrive to the whole cerebellopontine angle, and we have to work between nerves, but it's very versatile and very used, very easy accessed, and is to take into account in a lot of cases. It's said that maybe as if you have to work between nerves, maybe with these cases that the space between 5 and 7 and 8 is increased, maybe it's the best option because the damaging these nerves is less probable. And the far lateral, as we said, is for reaching this 1/3 inferior of the clivus. It's indicated for foramen magnum lesions, disease of vertebral artery, and jugular foramen lesions. For tumors with big medial part, the endoscopic approach is a very good tool because we keep this philosophy that do not cross the nerves, that it was said by Amin Kassam. And I think for these tumors is very interesting, and we can perform good resections. It's well said that maybe for big lesions we can do 2 stages. The medial portion of the tumor we can perform this endoscopic transclavial approach, and for the lateral part we can perform this Kawase approach or even the retrosigmoid approach. Examples of cases. We begin with one of the most challenging lesions, that is petroclival meningioma. It's a little bit confusing that what is considered a petroclival meningioma, and by definition, petroclival meningioma grows from this petroclival junction, and by definition is medial to the trigeminal nerve, and it's located in this 2/3 superior of the clivus. So from that point, it can grow towards the cavernous sinus, towards the middle fossa, or towards the posterior cranial fossa. So the first case I would like to present is this patient of 63 years old with ataxia and dysphagia. You can see these huge tumors that it was pressing the brainstem. We perform a combined transpetrosal approach. This was the incision. This is the position. This is the mastoid. This is our neurologist making the retrolabyrinthine approach. This is the labyrinth, the facial nerve, and we perform later. This is the middle meningeal artery. We located the ESPN to do before doing the peeling of the middle fossa. After locating these structures, we drill this area of Kawase to have access to the posterior fossa. After that, we open widely presigmoid and subtemporal, and we cut the tentorium, taking into account not to cut the 4th nerve that is here. So very important to cut the tentorium because it's part of the feeding of the tumor, and with that, this is when we relieve the trigeminal nerve, opening the presigmoid dura mater. This is the lower cranial nerves, 7 and 8, and the trigeminal nerve. We begin with the bulking, coagulation of the implantation base, and releasing the nerves from the tumor. Progressively, a lot of hours of surgery, trying to find the arachnoidal planes. This is the fourth nerve, and coagulating this progressively. This is the third nerve, fourth nerve. We leave the tumor that is third and fourth. This is the tumor that is extending inside the cavernous sinus, and we leave it. We try to suck to the suction of the tumor, but we leave the tumor inside the cavernous sinus, and this is the last part and the last dissection of the tumor. And this was the final part, the hemostasis. So the patient, this was the postoperative MRI. This was a good resection. This is fat, but we leave some residual in this inferior part of the approach. This was the meningioma grade 1 with a Chi 67 of 4%. And the patient recovered progressively. He recovered the 6 and 7 in 6 months. We follow the tumor with MRI. We find this tumor that grows with time, and as this tumor was overall in the middle part, we perform an endoscopic endonasal approach, transclival approach. This is the dura of the pituitary, the dura mater or submedial and inferior part of the clivus. We open. This is the sixth nerve, right sixth nerve. We make the bulking, and this tumor, the tumor was very attached to the vertebral artery and to the basilar artery. So there were a lot of perforance that we leave. We make a subtotal resection without risking our patient, because it was very, very attached to these structures. This was the reconstructions. And this was the MRI. There is some residual of the tumor where here is the cavernous sinus, the entrance of the sixth nerve. He recovered the 6 and 7 in 6 months. He had a mild ataxia, and we performed radiotherapy in February, and the tumor is controlled till now. The second case I would like to present you is a giant trigeminal schwannoma. This was the tumor. The patient was 37 years old. He presented with cephalea and progressive instability. This was the image. And we perform a retrosigmoid approach. This was the craniectomy, and we open the dura mater as always. We release CSF from the inferior part, making the bulking of the tumor, identifying the 7 and 8, that is here, and the tumor was very cystic. This is the 7 and 8, and this is the lower cranial nerves. We dissect the tumor between the nerves, and we try to find the arachnoidal plane, but it was very attached to the brainstem. We find also a superior petrosal vein that, well, it was difficult to this is the SCA, to remove the tumor from this superior part, because we have to work between this vein. So when we feel that we don't have very good control of this superior part of the tumor, we leave the remnant and we wait for the MRI, and we will see what we will do. This is the final part of the resection. So this was the MRI. We leave the remnant attached to the brainstem, and this part of the tumor that it was attached to the trigeminal nerve. We are following this patient by MRI, but there is no growth in 2 years. So we are watching him. And the last example that I would like to show you is a patient of 55 years old with right hemiparesis and left 11 and 12 paresis. This was the tumor, a foramen magnum meningioma that falls down to the cervical craniocervical junction. And in this case, we perform this transcondylar, suboccipital transcondylar approach. This was the incision that we preferred because we lift the scalp and the muscles in one layer until we find the vertebral artery. So this was the position, park bench, and well, after exposing the bone, this is the suboccipital craniectomy. We are trying to find the vertebral artery in the suboccipital triangle. This is the C1 laminectomy, and this was the artery, and we deattach this venous system that is around the vertebral artery to expose this part of the condyle. We drill just the posterior part of the condyle, and we open the dura mater. When it's done, we open the dura mater. We can see the tumor. With this approach, we can expose this foramen magnum, this anterior part of the foramen magnum, the jugular foramen, and well, after that, this is always the same. The booking coagulation of the case, trying to find where is the vertebral artery, very important. The vertebral artery will be like here, and yes, the 11 rootlets, it's here. We can see the 11 rootlets, the vertebral artery is here, and following the arachnoidal planes, we try to remove all the tumor. In this case, we have to leave one piece of tumor attached to the medulla, because every time we try to divide the tumor from the medulla, the potential evoked, the motor evoked potential went down. So we leave a little bit of tumor close to, attached to the medulla. It's important to know when to stop the surgery. This was the postoperative MRI. The patient went well, recovery of the strength in right extremity in 3-4 months, and the gait was autonomy in 3 months. Well, messages to take home. For example, well, the posterior skull-based tumors is high-risk surgery. They are usually benign tumors, so you have to take into consideration this, because sometimes they have mild symptoms, and after the surgery, maybe they will have some sequela, and it can have a big impact in the quality of life. Sometimes the best is the no treatment, and in these asymptomatic or pathysymptomatic patients to follow up if the tumor grows. The decision-making process is the key. Patients should be involved, should be informed of everything that can happen after the surgery. Sometimes subtotal resection is the best option, and it should be treated with a multidisciplinary team in school-based centers. It's important to practice in the lab, in the cadaveric specimen. We in Spain, we organize every year one school-based course. This time is middle fossa approaches with to see the cavernous sinus, and also we will perform the transorbitary approach. It will be in Spanish, but if someone is interested, he can find more information in this web. As my previous colleague said, it's important to be man, do no harm, because maybe, well, these kind of lesions, as a neurosurgeon, we want to remove it, but it's important to know that if we are not prepared, maybe even the patient and we can be damaged by this tumor. So it's important to be in mind, if you are not ready, it's better to go to a center that have a lot of experience, of to send to a neurosurgeon that have enough experience. Thank you very much for your attention, and I will be grateful to answer all the questions you want.
Well,
Nice.
Dr. Fernando, first, congratulations for your amazing presentation. I think that school-based surgery is a big challenge for every neurosurgeon. So the presentation was really amazing, wonderful cases, wonderful pictures. So,
thank you.
Any question? I'm the moderator of the event right now. I don't know if any colleague have a question for Dr. Fernando.
Oh, just to
Thank you, Dr.
congratulate
Fernando.
Dr. Munoz.
Thank you very much.
Thank you, Dr. Munoz. Your presentation very nice.
Thank you.
So I have two questions. So the first one is nowadays we know that the approach to a school-based surgery could be done with
I'm sorry, but I can't hear anything. I don't know if the connection is not working. Sorry, I didn't.
Maybe he's lost or something.
Okay.
Very nice presentation.
Thank you.
Very nice cases and wonderful. I saw many pictures. When I was resident, Jack Morcos was chief resident in Minneapolis. So I
Yes.
was with him in Minneapolis with Dr. Heros at that time.
Yes, I was
So
with
nice.
them in 2008 in Miami.
Miami, yes.
Experience, yeah.
Good, sorry. Good cases. You have good cases.
sorry, I don't know what's happening. I think that the signal was presenting problems. So just to finish with my question, one of the principles, as I was trying to say before, is earn a space draining CSF. So my question for you is, do you advise to perform dural drainage, epidural drainage, continuous epidural drainage, or you just open the cistern when you perform posterior school-based approach?
Yes, thank you for the question. When I perform a subtemporal approach, if there is not a huge tumor that I am afraid to put a lumbar drainage, I usually put a lumbar drainage with subtemporal approach. But if it's a posterior fossa tumor, very rarely I use a lumbar drainage. I prefer, if it's a retrosigmoid approach, I open cisterns in just in the inferior part of my opening. I open the dura mater in this anterior and inferior part of the dura. I go through the posterior fossa to arrive the cisterna magna, and I release CSF, and later I can open the dura mater without any problem because the cerebellum goes down very easily.
Oh, thank you very much. I think that
For
it's a very
the
good advice. Thank you, and once more time, congratulations.
Thank
Very
you.
nice presentation.
for the lumbar drainage, I use in a frontal or extra axial meningiomas. Do you have any problem depending of the size of the tumor? You take account on that, or just for example, for subtemporal and transpetrosal approach, you normally use a lumbar drainage. Is this a big tumor? That's my question. Or not?
No, if it's a big tumor and I see that there is a lot of, it's like a high, it could be a high hypertension, intracranial hypertension, I prefer not to use it. I prefer sometimes, even before doing the peeling of the middle fossa, I make a small opening subfrontally, and I release the opticocarotid cisterns. I just make an opening, I go subfrontally to reach the optic nerve and carotid, and there is where I release CSF. Even though sometimes I put a lumbar drainage, and this lumbar drainage, after putting it doesn't work. So I do it. If I should do a middle fossa peeling, I prefer to release CSF. It could be by a lumbar drainage, or maybe to just open it by a subfrontal, and a small subfrontal approach.
Hernandez, I have a comment. First, I think this is a very beautiful presentation and a nice case that you present. For the subtemporal approaches, sometimes, like I would say, with the new techniques, that we open even the dura in high place, like over the cilium fissure, before we start the peeling of the middle fossa. And like we just make a small opening and we open the arachnoid, and that sometimes give you a relief of the CSF without the need of the lumbar drain for it. So this is one of the, I would say, the techniques that we use to avoid the lumbar drain in the subtemporal cases. But I believe that the case that you present is a very nice, very hard work in these cases. Do you do the combined approaches same day, or do you schedule it? Like, do you do the approach in one day as the Al-Mifty did and tumor section next day, or do you do it in the same day?
Yes, very good question. Sometimes I think about to do it in 2 stages, but for example, this case of combine anterior and transpetrosal, I have a neurologist that is really, really good. So this part of the mastoidectomy and retrolabyrinthine approach is made by him. So, well, I begin to do the anterior petrosal, and after that, I have more people I don't want to be operating 4 or 5 hours without rest.
Rest.
So
Correct.
as this first part, it's performed by my neurologist, I'm fresh to do it. We usually do it in one stage, but sometimes it's good to do it in 2 stages. Overall, if you will perform alone these kind of approaches.
Nice. Thank you.
You're welcome. Thank you for the question.
So if another colleague have another question, please. So I think congratulations, Dr. Fernando, once more time. So I think we are ready to continue with the next presentation of Professor Bamba. So please, Professor, welcome to this international webinar of neurosurgery and spine surgery. Be free to start if you are ready. Thank you very much.
Did you see my slide? Hello?
Yes,
Yeah.
Yes,
Okay,
voice.
thank you. So I'm a orthopedic spine surgeon. Sorry, I cannot join the discussion previously. This is a little bit different with our colleagues. Thank you for invitation. I'm working previously in the Army Central Hospital, but now I'm working in the private hospital and also lecturer in the medical faculty in Jakarta, the capital of Indonesia. So my topic is endoscopic technique for multi-level spine degenerative deformity. Do we need fusion? Nothing to disclose. What is aging spine? Is the natural physiologic changes of the biomechanic construct of the spine musculoskeletal system, experienced by everybody and could not be avoided, and leading to a kyphotic deformity. Life is progressive kyphosing event. What is spine degeneration? Degenerative is pathologic condition, damages, wear and tear, and change the biomechanic construct in the aging spine. Occur at any age, but could be prevented and be treated if the etiology is identified. The changes of the biomechanic construct in the spine might be single or multi-levels and lead to a deformity in cervical or lumbar spine. This is theory of Kirkcaldy-Willis, early degenerative cascade, posterior joint, intervertebral joint, and then go to the late degenerative cascade, lateral nerve entrapment, one-level central stenosis, and ending with multi-level degenerative lesion. We can describe this degenerative cascade in 3 phases: the dysfunction phase, instability, and stabilization, but in deformity. Actually, Kirkcaldy-Willis only described 2 columns, the middle column and the anterior column. But 45 years before Kirkcaldy-Willis, Bastrop already described the posterior column degeneration, development of new arteries between adjacent spinous process and breakdown the interspinous ligament, characterized by abutment, enlargement, sclerosis, and bursa. But due to limited studies on histologic and radiographic changes, the etiology was not well understood and his theory was forgotten in the clinical practice. But 2010, his study was supported by Bristol study and Auckland study. They study 100 standing X-ray, 200 CT scan, 200 abdominal CT scan between the age 20 until 90 and published in European Journal Spine at 2012. According to their observation, the lumbar spinous process getting larger and wider with age. From this become like this become like that. They call it the kissing spine. So if the width increased from 8 millimeter at age 20 to 12 millimeter at age 80, it increased 50%. And if the height increased from 23 millimeter at age 20 to 27 millimeter at age 80, it increased 30%. So if the height and width increase, then the lordosis decrease. Now, the loss of lordosis not merely due to disc degeneration, but also due to enlargement of the spinous process. Then we came to the three-column theory of cervical and lumbar degenerative cascade. It can be started from the anterior, middle, or posterior, may suffer alone or together, from inflammatory to compressive reactions, and changes the biometric construct of the spine mobile segment, either single or multi, and lead to a spine deformity. This published already in 2018. The dynamic movement of the cervical and lumbar spine, the tension band, load distribution, and sagittal balance need the natural stabilizers. That is the disc, facet joint, ligament, and muscles. This is all the stabilizer, the disc, facet joint, and ligament, and muscles. The cervical muscle stabilizer, we know this. And the pathologies in degenerative spine, we call it deformer. Osteophyte, like this. Hypertrophy facet, lamina, spinous process, and canal stenosis. Flavum infolding and hypertrophy. This is deformer in cervical spine, multiple disc ruptures. Ligamentum flava infolding, annulus rupture and nucleus extrusion. This is courtesy from Professor Wolfgang Rosning. Normal facet joint is a gliding joint in flexion and extension and in lateral flexion. Facet hypertrophy will lock the facet joint in deformity, like this, and like this. So, to lose the locking facet joint, we do a medial facetectomy. This is type of casing spine abutment, 4 patterns, type 1 end-to-end, type 2 hypertrophic, type 3 ball and socket, and type 4 oblique. And the abutment may be hard case, bone to bone, or there is a soft case, bursa in between. Let us see the deformer bus tube type 4, oblique abutment, produce torque across this level, and then lead to lateral listhesis and deformity. The nature of illness of deformity is a combination of 2 factors, the stabilizers and deformer. The deformer will dysfunction the stabilizer and then create instability and deformity in the cervical and the lumbar. So it is the nature of illness deformity, combination 2 factor, the stabilizer and deformer. The gold standard is open surgery decompression, but this some way will sacrifice part of the stabilizer. Then we need artificial stabilizer to re-stabilize, like this. But if we could preserve the stabilizer, do we need fusion? Long complication of fusion is adjacent segment disease, a condition that sometimes occurs after a spinal fusion surgery to join or lock 2 or more bones together and stop the natural motion at that level. Degenerative changes develop on the disc and joint above and below the level where a previous surgery was performed. This is sample man 78, already implant fusion C4567 at 2012. Then 8 years later, severe neck pain due to ASD at C34 and C71. We can see here severe stenosis, 34, and also C71. Then we perform endoscopic decompression, medial facetectomy, foraminotomy, laminotomy, and discectomy. And the result is before and after, before and after. The C71, before, after, before, and after. Now, the concept of endoscopy for spine degenerative deformity is retain the stabilizer, just remove the deformers. What we call is the first decompression. And the result is we will reapply again the stabilizer function, and in some way will reduce the deformity. We call it the second decompression because the best decompression is deformity correction. We use endoscopy, arthroscopy technique, diameter 8 millimeter, walking channel 5.5 millimeter, and closed system irrigation, suction and irrigation. The advantage of endoscopy using arthroscopy technique is docking system, closed system irrigation, so we can control all the water, wider horizon of view over the top, interlaminar, retaining stabilizer, and just remove the deformer only as a decompression. This is some of the cases. Man 71, low back pain, bilateral sciatica, lumbar degenerative deformity. Then we perform endoscopy, decompression, interlaminar, medial facetectomy, and discectomy L3445. Before, after, before and after, before, after. The result is deformity is corrected without fusion. This is before and after, before and after. Another case, man 61, 4-level degenerative cascade. This is the deformity. We also perform over-the-top endoscopic decompression before, after, before and after, before, after. Then this is before. 3 months later, there is a natural healing. By natural healing is disturbed and supported. The end is not the same because this is live tissue. After, before, and after. Deformity corrected without fusion. Another case. We perform the same endoscopic decompression over the top, medial facetectomy, discectomy L3445. Before and after, before and after, before, after. 3 months later, deformity is corrected without fusion. Another case, this is the same. We perform the surgery before and after, before and 3 months later, deformity corrected by natural, by the patient. So who heals is the patient. The doctor just to show the way and do something to help, but we should educate the patient how to help themselves heal completely and successfully. Another case, lady 62. This is the deformity and 3 levels. We perform the same things, and we can see here before, after, before, after, before, after, before, after, and 3 months later, deformity corrected without fusion. This is the worst. Patient bedridden tetraplegia due to cervical and lumbar spondylosis with deformity. This is the left hand, and this is the right hand. Yeah. And also the leg cannot move. And here we can see
ಅಲ್ಲಿ 90 degree ಮೇಲೆ ನೆಕ್ಸ್ಟ್ ಇಟ್ಟಾರೆ.
Yes.
90 degree ಮೇಲೆ.
This is the lumbar also. Then we perform endoscopy, decompression, foraminotomy, laminotomy, and discectomy. Here we can see the end results. All decompression already done. Removing the deformer only. And also the disc herniation, we removed it. And the result is before and after, before, after, before, after, before, after. Also deformity corrected without fusion. We perform the same also in the lumbar. Before, after, before, after, before, after, before and after. And 3 months later, before and after. So the patient start to move the right hand, the left, so the leg. Starting to walk.
Yeah. Yeah.
No fusion. Take home message. Endoscopy is developing instrument for degenerative spine. The concept is how to use it for cervical and lumbar degenerative deformity. Retain the natural stabilizer, disc, facet, joint, ligament, and muscles. Just remove deformer only, osteophyte, hypertrophy, facet, disc, herniation, flavomina folding, etc. This will naturally reapply the stabilizer function and will correct the deformity without fusion device. The best decompression is deformity correction. The concept is applicable for solving the lumbar, cervical, thoracic spondylosis, either early or late cascade of spinal degeneration, or other pathologies, either single or multi-level. We publish in this. Thank you very much for the kind attention.
Thank you very much for your beautiful presentation, Dr. Bambang.
Yeah, please, if there are any question, I will happy to answer.
Professor Bambam, first, congratulations. Wonderful presentation. I think it's amazing
I would
the
like to
outcome
ask
of your
that
it's really
Bambang was our previous speaker. Could you remember him? Could you recognize him?
before in other international meeting.
Yeah, I think in April.
Yes, of course. I remember him. So,
Yeah.
but anyway, this presentation is really amazing. I think that for all spine surgeons, we will start to change our mind starting from this point. So my question is, normally when you perform interlaminar endoscopic decompressive approach to the spine, after surgery, do you use any kind of external orthosis, like, for example, for cervical spine, like a neck collar, or for thoracolumbar spine, I'm talking about the Taylor corset, or for lumbar spine, a lumbar belt, at least for 3 weeks after surgery, just for protection and be sure that everything will be okay. Let's go to say like this. Thank you very much.
Thank you. This is a good question, yes. But we should understand that the problem, we facing the live tissue, not a machine. If machine, you change the broken screw and put in this and this, that's finished, yeah? The live tissue, there is a natural healing after the surgery. The natural healing needs three months, yeah? So I still put the soft collar neck or the lumbar brace. Why? Just to remind the patient. Because usually they feel no pain and then forget everything about the natural healing. Yes, because if the same treatment, one is disturbed, one is supported, the end is not the same. So we should educate the patient, not allow to bend and leave, because the bone is not healed completely. If you put a more burden, it will break the bone. But after 3 months, then you make a dynamic X-ray, all stable, you remove the brace and start to do strengthening of the back muscle, because we already make it weak for 3 months by not mobilize.
Thank you very much. Thank you very much. I think that answered my question. So one more time, congratulations.
Yeah.
Thank you very much for your knowledge and this.
Give me a minute, please. I would like to inform that Dr. Bambang Darwono was a retired colonel of Indonesian Army.
Thank you. Yes. I'm
Yeah,
working
and
in Central
he,
Hospital and then retired and now in private hospital. Yeah. Thank you.
yeah, and he has many professional qualifications since 20 how many years, Dr. Bambang? I
Oh,
think 1994 or something, right?
1990, I start my job as orthopedic surgeon, and then I was sent to Japan to learn about the percutaneous lumbar discectomy from Professor Sadaisa Ichikata, the founder of this technique, and sent to many places to learn in
Yeah,
the
you are
Dallas.
having maximum 16 to 17 major publications, right?
Oh yes.
Yeah, that's very great. You're really very highly experienced. We're really very happy to see you in this platform. And we hope your presence, according to your availability in further conferences also.
Yeah.
Consulting activities and your academic awards, your services. I will definitely share your CV through WhatsApp group that everybody can know you.
Yeah. Thank you. Thank you.
Not knew your experience, but I'll try to inform. Thank you. Thank you so much for the presentation.
Thank you for invitation. Thank you to see all the colleagues here and sharing the knowledge. Thank you.
Sure, thanks.
So, Dr. Damian, let's
Are
go.
we done with the HR session?
Yes, I'm Yali. Thank you very much. So I'm ready to start my presentation.
Hello to Dr. Gabriel Vargas. Please continue. If you have any discussion, then please continue.
No, just to say that very good and very good thinking about the spine. Thank you very much for this lecture and good experience and very different concepts than today's approaches, because everybody wants to fuse everything. So
Yeah.
coming from the orthopedic surgeon, this concept is a very good, very nice, and congratulations. Thank you very much.
Me too, Dr. Bamang Darwano is also having another topic to present. Let me inform you the topic that is about.
Wait, I'm trying to share my
That is
screen.
about and brain injury. Could paralysis be cured? So we have a gap of 1 to 2 sessions so that he can continue his second topic again. So now I request to Dr. Damian to continue his presentation.
So thank you very much, Anjali. So welcome all professors, colleagues, students to this international meeting about neurosurgery and spine surgery. So, allow me to introduce myself. I'm Dr. Damian Lastra, consultant neurosurgeon. I'm currently working at Charab Medical Center, Banjul, Gambia, from Cuba. My field is spine surgery and neuro-oncology, and also ICU care for neurosurgical patients. So my presentation will be a case report about a patient who suffered a malignant ischemic infarction of the middle cerebral artery, and we perform the compressive craniotomy. Not too much common technique with the size, but we get a very good outcome, a very good result on this case. So we'll see through the presentation. So I would like to start my presentation with some words pronounced by our eternal father, the eternal father of neurosurgery, Dr. Harvey Cushing, who said that every patient provides to us two questions. The first question, what can be learned from him? And the second question, what can be done for him? So I think that is a very good point to think and to see that we can learn a lot for each patient, because each patient is a book of medicine for us, and is a challenge that we can take into account with the aim to offer the best for the patients always. So as a concept, the malignant middle cerebral artery infarction is defined like a sudden obstruction of the blood flow at the irrigation area of the middle cerebral artery that could be caused by ischemic thrombotic infarction or cardioembolic etiology. From the epidemiology, is a very often health condition, and one of the most important epidemiological history, who includes both types of cerebral and vascular disease, reveal that the annual incidence per 100,000 patients is between 218 and 127 for male and female patients respectively. So the mortality reported at 28 days after a stroke, after suffering a stroke, was 36%. And the mortality outside the hospital increased to 62.5% of the cases. Until a few years ago, this was considered a very mortal disease, a fatal disease, health condition, since the mortality was associated to more than 80% of the cases. In this unfavorable context, the compressive craniotomy as a treatment emerged as an effective therapeutic alternative in selected cases, reporting a decreased mortality between 15 and 40%. But even with this advantage, we need to be clear that we are in front of a patient with a critical condition who present a progressive increase in cerebral edema, increase of intracranial pressure, decreased cerebral perfusion, and a progressive degradation of consciousness, and still associated with high morbidity and mortality. So the compressive craniotomy is a removal of a considerable part of the cranial vault associated with a durotomy of the exposed area, with the purpose of increasing the volume of the intracranial continent and decrease the intracranial pressure of the patient, relieving the mechanical compression secondary to the brain edema, secondary to middle cerebral artery infarction, and the displacement of midline structures. From the historical perspective, there are evidence that Hippocrates as a treatment for patients who suffer traumatic brain injury, this kind of treatment, and multiple research and investigation was performed until 1905 that Dr. Harvey Cushing published the result obtained with subtemporal craniotomy in patients with intracranial hypertension secondary to brain tumors. So there are some requirements to achieve the effectiveness of this kind of technique. That is that the extension must be greater than 12 centimeters or exceed the margin anterior and medial cranial base to avoid herniation from the free edge of the dentorium. It should be accompanied by a dural extension, duroplasty, preferably with autologous tissue. We can use subgallic tissue, but most commonly we use fascia lata of external vastus muscle on the lower limbs. And there are different types of the compressive craniectomy. We have unilateral hemicraniectomy, bifrontal craniectomy, Tony's approach, or modified bilateral frontotemporal parieto-occipital, the compressive craniectomy, the trauma flap, and most recently the hinge craniotomy. The main indications for this kind of technique is the neurointensive treatment for patients with severe traumatic brain injury and severe intracranial hypertension syndrome. Could be primary or secondary decompressive craniectomy and the malignant infarction of the middle cerebral artery, plus severe intracranial hypertension secondary to malignant mass effect due to space occupation lesions. The surgical criteria to perform this kind of technique is in patients with grade 4 and 6 of Marshall Imaging Classification Scale, intracranial hypertension greater than 25 millimeters of mercury with refractory to the first level of neurointensive treatment measures, age less than 65 years, and a Glasgow Coma scale greater than 3 points at the time of patient admissions, plus the displacement of the midline structures more than 5 millimeters. So we present the case of a 45 years old patient who arrived to our center with a sudden and progressive degradation of the conscious state. He is received in the emergency room with 8 points on Glasgow Coma scale. When we perform the fundus eye, we identify papillary edema with a total and proportional right hemiplalia, motor aphasia, and positive Babinski sign, Dupre-Fan sign, bradycardia, hypertension, and respiratory difficult, Cushing triad. So immediately we transfer the patient to ICU to start the opening of the airway through orotracheal intubation and start invasive mechanical ventilation for the patient, hyperventilation with all the neurointensive measures with the aim to decrease the intracranial pressure. So the report of the MRI, we decide in the first 24 hours perform an MRI history investigation. The report of the MRI show an area of ischemic cerebral infarction in the right hemisphere that involves the territory of the middle cerebral artery with an extensive area of associated cerebral edema that compress and displace midline structures more than 5 millimeters with irresolute of the sulcus and gyrus of the brain. So here we have 2 slides of the MRI T1 and T2 sequence, and it's evident the displacement of the midline structures to the opposite side. Is we confirm that the patient suffered a middle cerebral artery ischemic infarction of the left hemisphere. And we decided to perform a frontotemporal parietoccipital hemicraniectomy with a size of 10 per 12 centimeter according to the craniometrics of the patient. This was a patient with small craniometrics. So with this size, we can achieve the compression of the frontotemporal parietoccipital area of the left side. We perform a duroplasty with fascia lata of the vastus external muscle, marsupialization of the bone flap in the left lower limb, and after that, we keep the patient in ICU under mechanical ventilation for 72 hours. The patient was extubated after 72 hours and with a very good outcome. And posteriorly, the bone flap was repositioned 11 months after the first surgical procedure. So here we have some image of the surgical approach. We can see that with the craniotomy performed, the swelling of the brain decreased a lot. So we don't get any complication as transcalvarian herniation. After the surgery, we perform a durotomy in a start shape, and finally we perform a duroplasty with fascia lata to give more space to the brain, getting a very good outcome. We can see the post-operative MRI. We can see that all the midline structures regress to the normal place, and the anatomy of the brain become much normal as before surgery. And the result after surgery was, of course, regression of signs of intracranial hypertension, regression of motor defects, then hyparesia. The patient continued, with hyparesia, with predominant in the brachial strength. Even with the aphasia condition, the patient start to produce some words and obey orders, conscious and oriented, with a Glasgow Coma scale of 15 over 15 points. So this is a picture of the patients 11 months after the surgery, and we can see the improvement of the patient with this decompressive craniectomy. This case was awarded by Medshare platform in 2023, and this is my small presentation. Thank you very much for attending my case report. So I'm able to answer questions. Thank you very much. This is the bibliographical reference.
A very nice presentation. Thank you. So what is your usually time to replace the bone back? What is your timeline? Are you stick to a timeline, or depends on, what is the patient situation?
So normally, attending to all the research and investigations, we can replace the bone flap between 9 and 11 months. But the most important is see the evolutive imaging study. For example, after 6 months, between 3 and 6 months, we can perform an evolutive MRI to see the evolution of the brain edema, and if everything is okay, we can perform the second surgery to replace the flap, the bone flap.
Thank you.
Thank you very much.
Geet, are we done with the first session for today?
Sorry, I cannot hear you.
Congratulations for your case.
Thank you very much.
Always you keep the bone of the patient, or you sometimes try to do an cranioplasty with other materials, or always you use the own bone of the patient.
We try to use most frequently we try to use the own bone of the patient, but other times when the brain edema is very high, let's go to say like this, and the surgery was done in a premature way, we can use also another kind of material like methyl methacrylate to perform a cranioplasty. But most commonly, we use the autologous bone flap. We can put the bone inside the abdominal cavity or between the muscles on the lower limbs, attending that we take the fascia lata from the lower limbs. So like this, we avoid perform two incisions for perform this kind of technique. Well, thank you. I don't know if another colleague have other questions.
Yes, hello. Hello.
Yes, hello.
Did you hear me?
Yes, hello, please.
Yes, hello. It's Dr. Joanna Camijo Sanchez. Good morning, Dr. Damian. So I want to know if you have any experience. Did you have any experience in extraaxial lesions?
You mean extraaxial tumors? The compressive cranial?
No, I mean traumatic injury, but like epidural hematoma, some extraaxial lesions.
So for extraaxial lesions, the researchers describe that the main indication for extraaxial lesions like epidural hematoma and subdural hematoma is when the volume of the hematoma, sorry, when the displacement of the midline is more than the volume of the hematoma, causing a critical condition of the patient due to a severe intracranial hypertension. Otherwise, if the midline displacement is less than the size of the volume of the hematoma, we can perform a limited craniectomy or the classic burr hole and evacuation. But nowadays, the Professor Yep Cherian is also a pioneer on traumatic brain injury surgical approach, and he recommends also that we can perform a limited craniectomy plus cisternotomy, and he's achieving a very good outcomes of his patient only with cisternotomy. I don't know if I answer your question, Dr. Sanchez.
Yes. Thank you so much. Thank you so much. So in your practice, you don't have any experience with this kind of the compressive craniectomy for extraaxial lesion. You prefer the cisternotomy.
Yes, I prefer the cisternotomy. I performed one case was, but it wasn't traumatic injury. It was a spontaneous subdural hematoma with a very high volume and displacement of midline structures. And for that case, I remember that I performed an hemicraniectomy.
Thank you so much.
Thank you very much.
Thank you so much, Dr. Dam.
So, thank you very much. I think that, I don't know if Anjali is connected, but I think that we are on time to hear the next presentation. Is with Professor Bamba.
Yeah, the next presentation. Yeah, hello, Dr. Bambam. Could you continue? Yes, great.
Yes. Okay. Thank you.
Thank you very much.
This is my second topic, spinal cord and brain injury. Could paralysis be cured? Spinal cord, we know, consists of 31 nerve bundles, is a delicate and integral component of the body's central nervous system. And spinal cord injury are life-threatening forms of trauma that require different types of treatment depending on the level and severity of each injury. In acute phase, at the level of injury include paralysis to neuron involved in motor, sensory, and autonomic functions. And beyond the injury site, there is miscommunication in afferent and afferent white matter tracts transmitting signal. There is a Wallerian degeneration, and the chronic phase considered anywhere after 6 months post-injury. And what is left in the injury site is multilocular cystic cavity. And within 1 or 2 years, it is believed that the lesion has ceased to progress and continuing deficit are stabilized. Report from the WHO and East Coast, 2013. Spinal cord injury is a global incidence and global burden, regardless the age. And the report is including understanding spinal cord injury, global picture, prevention, healthcare rehabilitation needs, health system strengthening, attitude, relationship and adjustment, spinal cord injury and enabling environments, education, employment, and recommendation, but no report about the treatment. So innovative research is treatment for spinal cord injury. The prognosis of spinal cord injury, we know that all is primary injury, acute compression, impact, missile, distraction, and everything's trauma. And the secondary injury, acute phase, and then subacute phase, and chronic phase, and ending with glial scar formation, gliosis or astrogliosis. The central dogma in neuroscience for a long time by Santiago Ramon Aycayal, the Nobel Prize winner and father of modern neuroscience, wrote, once development was ended in the adult center, the nerve parts are something fixed and immutable. Everything may die, nothing may be regenerated. So the question is, could paralysis be cured? Why difficult to regenerate? Because there is a formation of glial scar and fibrous scar as a local immune response to protect the primary injury becomes secondary injury. The extent of the scar area related to complete or incomplete spinal cord injury. This is statistical prognosis of spinal cord injury by the American Spinal Injury Association. Asia A, complete no motor or sensory function. 94% remain Asia A. Asia B, incomplete sensory but no motor function, is preserved to up to 40% converted to C and D. And Asia C, incomplete motor function is preserved below the level of injury, up to 80% converted to Asia D. So the key point of therapy, because spinal cord injury is biphasic, initial to secondary injury, early intervention surgery to reconstruct the bony protective structure of the spine to prevent the spread of secondary injury damage is a promising therapeutic opportunity. and a better understanding of potentially beneficial the endogenous response, such as progenitor cell proliferation, axonal sprouting, remyelinization, angiogenesis, could lead to a novel therapeutic intervention. The endogenous response is astrogliosis. Reactive astrocytosis is an abnormal increase the number of astrocytes due to destruction of nearby neurons from trauma, infection, ischemia, stroke, autoimmune response, and neurodegenerative disease, almost to all forms of CNS injury and disease. This is exosome recognition pathway publication for regeneration, repair, regeneration, and hope for spinal cord injury repair, messenger in health and disease, and meta-analysis treatment for spinal cord injury, and also emerging exosome with profile of microRNA in spinal cord injury. Exosome was originally disregarded as a simple vesicle, now has become a hot research topic that has attracted attention of researchers worldwide. It is multivesicle body-derived mesenchymal cells, smallest vesicle size only 30 until 150 nanometer, and the function is as a messenger communicating with other cells. Here we can see the size compared to flu virus, very small, and less than the size of micrometer for cell. Because it is very small, then it's spread in the whole body. And the content then is uptaken by other cells, the cell target, and used for metabolism of the organelle inside the cell to improve the cell. Here we can see the profile of bioactive protein inside the
धनगढीमा अरु प्राइभेट अस्पताल पठाउनु भनेको आफ्नो अस्पताललाई कमजोर बनाउनु हो मेरो विचारमा।
And also the content of the microRNA inside. Now we can see complex with regulating adult neurogenesis. Activation and proliferation of adult stem cell, controlling the balance between quiescent and activated proliferative neurostem cell, regulating neurostem cell activation downstream of neurogenic modulators, modulate adult neuronal differences acting in concert expression regulators, regulating survival in the adult neurogenic nature, and regulating migration and neurate morphogenic adult bone neurons also may contribute in homeostasis of neurostem cell nature in healthy and disease condition. We can see a lot of microRNA function here from proliferation and here we can see from neurostem cell become a mature neuron. They also need a lot of microRNA. 2021 response following spinal cord injury. Expression increased the astrocyte adjacent to the lesion site, not only augmented the hypertrophic response, but also increased the number of exons within the lesion at chronic stages of injury, and also enhance astrocytic hypertrophy and modulate the progression of the glial scar to potentially increase function recovery after spinal cord injury. We can see also here's the microRNA 21 available in the profile of the microRNA inside the exon. Then we perform preclinical animal study. We use 30 New Zealand white rabbit and create artificial spinal cord injury using a screw. 3 weeks, and then we remove the screw. We got a complete spinal cord injury here. And then we find the group, control group, and 4 group, injection 1, 2, 3, and 4. Terminated. Here we can, the control is still paralyzed. But
दिनको चाहिँ त्यस्तो
1 week later, we can see starting to after injected 4 weeks for time, 4 months, come again.
Someone is with open microphone, please.
Here,
Mute the microphones, please.
Switch off the microphone. We cannot hear the conference. So,
Yeah, sorry. I have a mute.
Mic-
I have done his microphone off. Yeah. Sorry
Okay.
for the risk. Sorry.
I continue. So this is
Yeah.
the histopathology. Histopathology we can see here. This is the normal spinal cord. And this is after chronic spinal cord injury and then injected 4 times and become normal again. This is the normal spinal cord. And then this is the scar in chronic spinal cord injury. And after injected 4 times, become normal again. And this is the immunohistochemistry, CFAP, MCP1, MMT1, TGF-beta. This is normal and no treatment. And after 4 injection, back to normal again. Here is angiogenesis marker. This is normal. And after 4 injection, we can see normal and reactive angiogenesis. Now this is the case. Male 48, spot injury 9 months. And after injected with exosome intrathecal, we start to move. You can see here all the muscles at 0, cannot move, and then it start to move. Another case, male 69, tetraplegia, has degenerative stenosis, lumbar, but also already operated in another hospital with a wrong screw placement, 4 months. Then we remove this and do a minimal invasive decompression. And we can see here in exosome intrathecal, and this is 1 year. Start to move. This is another case. Male 40, 1.5 years stroke, wheelchair, right hemiplegic, motoric aphasia. Then we inject with exosome intrathecal, and 4 times after 4 months later, after 4 time injection with the interval 1 month, no aphasia, walk without wheelchair, no conversion or tremor, and start to.
Hello, Dr. Bambang. Could you please unmute yourself?
Okay, thank you.
Yes.
So you only move like this, as you see, and then we injected intrathecal 4 times, and 4 months after, one year. And 5 months, we start to do a jogging. This is male, 77, 8 years non-hemorrhagic stroke, right hemiplegic wheelchair, and already operated and put stem cell into the brain, but no. And we can see here still. Then after injecting 2 times intrathecal with interval 1 month, it start to. This male, 19 cervical accident, 3 years already. And we can see here, very spastic, cannot sit straight, and also. Then we inject 2 times, and we can see he start like this, and 4 months later. This is male, 4 months already brainstem stroke, tracheostomy and gastroscopy, and we injected 2 times, and 2 months later.
Wih, Pak, cakep. Lahirnya udah nggak dipegangin
And 4 months
kuat.
later,
Iya. Wih.
males 17, 1 month, fracture C5, tetraplegic Asia A.
Bisa, Pak. Oke. Yang
This is
satunya?
0, muscle chart.
Oke.
You can see here,
Genggam bisa?
only move
Nggak
like
bisa
this.
ya, nggak apa-apa. Nanya aja ya. Terus saya bisa ikuti nanti perkembangannya seperti apa. Oke.
Then after injection, just 24 hours.
Terus ada pesan nggak kamu? Kepala ke
1 week
kiri.
later, you can grab
Sekarang.
glass.
Ini mau dikirim ke
Hello, hello, Dr. Bamang, 1 minute,
Weeks
please.
later.
Could you tell who is in unmute? Mute, because I have almost muted everyone, but I can't find out whose voice is reflecting. Is it yours or is it anybody others?
Oh, this is mine.
Okay, yours. Okay, no problem, no problem. Thank you.
Then 4 weeks later, 8 weeks.
Semangat ya, Jo. Oke, harus semangat, Jo. Ini mau berapa menit? 10.
Bentar.
Nanti mau
Tangannya.
This is male 49, 2 years already, spinal cord injury, complete Asia A. We can see here the right hand and also the left hand like this. Then we inject exosome intrathecal 1 month after injection. This is 1 month after the second injection.
Gerakkan tanganmu. 1, turun lagi. Ayo. 2.
This is another case. Male, 12 years old. Since 5 years before, has difficulty disturbance in speaking, walking, and visual disturbance, and came to our hospital like this, cannot move anything. And from the laboratory report from Boston, this young, this boy, diagnosis is adrenoleukodystrophy, a very rare disease, no treatment yet available. And in Indonesia, this is case number 15. We can see here also the MRI from 2020 until 2023, brain atrophy. Then we inject exosome intrathecal. We can see here 1 month later, starting improve the muscle chart. You can see before like this. 1 month after injection. And this is after the second injection. So as a summary, latest on spinal cord and brain injury, early intervention surgery is promising therapeutic opportunity to reconstruct the bony protective structure of the spine and to prevent the spread of secondary injury damage. Cure the paralysis using novel therapeutic intervention to support the endogenous response in natural healing. Use mesenchymal cell exosome, a nano platform 30 until 150 nanometer, potentially beneficial for therapeutic delivery as a vehicle carrying a bioactive protein and microRNA, including microRNA 21, and could cure paralysis in animal study. And in some cases of spinal cord injury, CNS brain stroke, and a rare case of ALD. These are the references. Thank you very much for your kind attention. Okay, please, if there are any question, I will happy to answer.
Thank you so much, doctor. Thank you. Your presentation was really nice. Presentation. Yeah, hello. Sorry, I was muted.
Yeah,
Everyone to ignore disturbances. Now it's okay.
uh, excellent presentation, Doctor. Amazing cases. Sorry. MicroRNA is used for many things right now, brain tumors and many things. But how difficult is to prepare these exosomes, and where we can find a protocol in order to try to do this? Because as you understand, if you start to use this, maybe we're going to be accused of use experimental things and something like that. But as you show us today, this is a very impressive results. So please let me know where I can find. You show the reference, of course, but how can I try to know more about this protocol of exosomes and how to prepare and how difficult is to obtain these molecules, nanoparticles?
Okay, thank you for your question. Yes, so we know that we start previously from a stem cell, right? Stem cell is cell that become so many other cells, but the stem cell itself is stupid, doesn't know what to be. Second, if we want to use stem cell, we should multiply stem cell in laboratory until many thousand, and then inject to the part of the body. So you know that stem cell is identified by the T immune of our body and attack. And from many thousand injected, survivor only less than 1%. From 1%, part become the cell what we want to be, part not. So stem cell treatment in general, yes, hype or hope. So many advertisements, so it's like a hope, yes. But I don't say that stem cell is or other treatment is bad. No, all treatment is good. The best is how to use them. Like you have a good car, but the driver not good is the same, yes. So that is starting point of our research in my country. We isolate stem cell in media without antigen and made it stress condition. Many kind like hypoxia, whatever it is. So what happened? The stem cell try to be still survive and excrete from the cell more than 100 bioactive protein. That is the paracrine effect. And we collect all this, that what we call the secretome. But secretome only can, in a short range, around the cell. The second step, from the family of the secretome, we find the exosome, the smallest particle. Because the small is spread all over our body. Also in the breast of milk of the lady. So now we open the secret. If you drink the milk of the cow, there is the exosome of the cow inside there. Yeah. So exosome can bring the good content or bad content. So if you have a malignancy, they also bring the malignant cell content to others and spreading. Yes, also in a COVID like that. So what is the best content of the exosome is the embryo. But the embryo is not allowed by ethical and religion. So we take from the healthy embryo just delivered by healthy mother, the umbilicus and the placenta, the cell. Because if umbilicus is 1:1, cell 1:1,000,000. So we have a bank of that cell. And this is how we produce the exosome from that. This is in lab, not mine. I have another team to do that, yes. And also approved by the FDA in my country. You are muted, Miti. Yeah. Hopefully I can answer your question. Any other questions?
No, thank you. We need to learn a lot about this, and thank you very much for this very good.
Yeah, actually, Dr. Bambang was in very busy schedule. We requested him a lot to attend this, and I think he'll be traveling to somewhere else within half an hour.
Yeah, sorry.
So we
I
will
should
definitely
go
miss
to
him.
the
We are
airport,
gonna
go
definitely
to
miss
Serbia.
you for the other seasons now.
Yeah.
But we request you whenever you will get time within coming 6 to 7 hours, please try to join.
Sure. I am on my way. If I have chance, I will reconnect again. Okay. So sorry, time should go to the airport to go to a CICOT meeting in Belgrade in Serbia. Thank you very much, all the colleagues, for sharing the experience, and apologize I should leave earlier for a while. Thank you.
Thank you very much, Professor. It was a great pleasure.
Thank you.
Thank you.
Your presence here in this meeting. Thank you very much.
Yeah.
Thank you to Professor Gabriel Vargas also, and all the colleagues and speakers.
Yeah, so there is a break mentioned, like a half an hour break. Shall we continue the break or shall we go for the next presentation? I think Dr. Duong Trong is not available at the moment. Let me check. Okay, he is not available. But Dr. Nicolas Sirmos, are you available? I'd like to connect with Dr. Nicolas Sirmos. Sorry, Dr. Nicholas, are you there? Okay, think he's not available to connect. So the next participant is Dr. Ali Haider. He already written us that he'll join within a half an hour. So okay, that's okay. So can anyone will be available to present your presentation? Like Dr. Tornike, Dr. Song Kunefang?
Yes, I can. My presentation. Give me a
Yeah.
minute.
Okay, who is this?
It's Tornike.
Okay, fine. Okay, let's have a 5 minutes break. People can discuss, or you people can go for a small break. Let's start this meeting after 5 to 10 minutes. Okay?
Okay, I will share my screen.
Yeah. You
When
can
you will say we can start.
you people can discuss, or you people can whatever you like to do. There will be a break. Okay?
Okay, I can when you say. Oh, you say.
Okay. Yeah, Dr. Tonike, shall we start our presentation? Hello, doctor. Hello, Dr. Tonike. Are you there? Okay, you can't unmute. Okay, sorry. Let me check once. Okay, see now, please. Okay, fine.
Yeah, do you hear me?
Yes, I can hear you.
Okay. Okay.
Please start your presentation.
Okay. Greetings from Georgia, Tbilisi. My name is Dr. Tornike Buldashvili. I'm a neurosurgeon in Tbilisi Caucasus Medical Center. And I'm working most of like a spinal neurosurgeon. And now I wanted to make some little presentation about C2 fractures, about the surgical treatment, and about our experience to do this type of surgery. Okay, first of all, let's speak about anatomy that we have, that why I'm showing here in C1 and anatomy and also C2, because C1 vertebra also use it in surgery of, in odontoid fractures. That's why we need to know about anatomy about this vertebra. And most important things, what we must to know in C1, it's a transverse ligamentum. Then why I will say in next slide is. Also, we need to know about arches, articulars, facet, as of course, and arch. Okay, about C2 that we see it's odontoid process. Also we see body, spinosus processus, lamina, and vertebral facets. Well, what we can say about epidemiology of this problem and this is most common fracture of the axis. Account on 10 or 50% of cervical fractures, it's odontoid fractures. It's most common in elderly patients without traumatic symptom. In demography, we can say it's more the most common in elderly patients than in younger patient. It can be in elderly patients, can be caused by a simple falls or some even movement, and this what can be made this type of fracture. And also most in young patient, it can be most traumatic as like hyperflexion and or hyperextension. This can be in car accident, for example, and motorcycle trauma or falling from height. What we can say about mechanism of this injury? There are two types of hyperreflexion and hyperextension. Most common is we have hyperreflexion when we have movement forward. What we can say about clinical presentation? It's most common is just neck pain. The patient can come only with neck pain, not, no neurological deficits or no some other symptom only. Neck pain in some time is not huge pain. Patient can say that I have discomfort in discomfort feeling in my neck. That's why they made some X-ray or CT scan. They also can be some symptoms like dysphagia, but it's maybe present when associated with large hematoma. Also, neurological deficit is rare, but if it's happening, it's give a huge nephrical like a tetraplegia or some quadriplegia. It can call also, and also problem with breathing and other high-level spinal trauma when we have. How we can find this type of fracture is classically what we use in, for example, radiology is X-ray, CT scan, or MRI. For example, on the X-rays, we can see here C2 and C1 fracture line. Here we see CT scan in sagittal and coronal view. Here we see in sagittal view fracture, and here is coronal view. And also MRI. Why we made MRI? When, for example, when we have already we see on CT scan we have fracture, and we know what type of fracture is, and we need operation. Why we made also MRI? If we don't have some neurological deficit, when we know that we don't have spinal cord injury, we made MRI to find have we damage or not transverse ligamentum, because transverse ligamentum is helping us to stabilize odontoid process. That's why we made MRI to find have we damaged this ligamentum or not. And also, when we see a fracture, we must decide what we do with this fracture. The helping is gold standard of this classification is Anderson the Alonso classification. There are 3 types of fracture, and we already know what to do in fracture, what type of fracture we have. For example, when we have only first type of fracture, it's where obligate abyssal fracture of tip of odontoid, or tip type 2 fracture through the base of the dents. Here we see, for example, and fracture through the body of C2. And also we have next classification, a Royal Camel classification of odontoid fracture, but I think, in my opinion, Anderson classification is it's enough to decide what to do, what type of surgery we can use, or we need surgery, or we don't need surgery. And there also classification. It's of line fracture, where is going, horizontal fracture, posterior or anterior. And for example, type of one of fracture, Anderson classified, not need surgery. It's enough for immobilization or 20 weeks, collar or hollow infection. In our times, it's more rare to use hollow fixation. It's more collar fixation, and fusion is near 100%. In most common type on X-ray, we don't see the first type of fracture, and even some patients don't use collar, and fusion is 100% without some there from sterilization of, for example, collar and hollow types of mobilization. But that's called rigid collar. It's called type 3. Why not type 3? Because of type 3 also can be managed like conservatively without surgery. It's immobilization, hollow because it's fixation and the stabilization and rigid collar. So 50 or 70%, but I think it's more than old sliding at old presentation. Also the factors what we can use in a type of 3 fracture, it's like age, medical contributions, and also etc. If for example, if shallow type of 3 equal to type 2, if the more than 5 millimeter distraction or not maintain reduction, then we consider surgery. And type of 2 fractures, then we have more treatment options. For example, we can try to make immobilization. If we don't have time or we don't know how to do this type of surgery. Not all surgery can do this surgery. For example, or not everywhere can be made surgeries, this type of surgery, and that we have a chance to treat patient with collar, but it's better to make surgery. It make time and send patients where they can about surgery. For example, I think most easier operation odontal screw, we can transfer the momentum intact and fixation orientation. I said we make MRI for when we have this type of fracture that we have traumatized or not transverse ligament. Also, we can use posterior fixation where when we made C1 and C2, we speak about anatomy of C1, that because we must put screw in C1. Also, we have C1 and C2 lateral mass articular screw fixation, C1, C2 lateral mass fixation, transarticular fixation, translaminar fixation. There are also all type of study like Halifax clamp fixation and C1, C2 wiring. And in our days, less 2 type of surgery, it's used very rare, and when we don't have another option. Surgical indication when it's placement more than 5 millimeter, angulation more than 10 degree, fracture communication, delayed treatment. For example, when we find fracture after 2-3 months. Patient come to us and we see there no fusion. More than 50. Treatment. It's for the first most common anterior fixation of screw. It's one section is here we see how patient see where everyone has the same place. We plan a fluoroscopy. It's helpful. You don't need to use one fluoroscope. You already see anterior view and lateral view. And when you have both view, the operation, for example, half hour, not more. For example, my surgery was 14 minutes skin to skin, because we could use two fluoroscopy, and it's very helpful, and it's helping you to make operation to save time, operation save anesthesia, and more and more. It's incision, for example, how we going. The surgical technique, how we made this type of operation. I think it's will be much more neurosurgery and colleagues. So it's for example, in a couple of cases I want to show. For example, first a patient 63 years old without here with fracture, line of fracture. Stabilize this fracture. Patient is without any neurological deficit after surgery. Here we have older patients, 8 years. He had problem with posterior. That's what we trying to make anterior. Fortunately, it was fixation and also 1 month. Next one is deficit, and here also made screw fixation. MRI scan, and we saw I don't have photos. We knew the transverse ligament was damaged. That's why we made screw fixation. But neck was anatomy of neck and thoracic part. Why is you not so beautiful how it must be? Step about posterior fixation. Now C1 fixation. In C1 we have put screw. C2 we have a couple types where we can put screw. Most common we use part screw. It's easier. And it's both more. The next one is include laminate. Not from let's pick a classic. You can see two wiring operation. It's old technique in our other country, but in Georgia we don't. It's what was helpful. business and not our time. Next one is tax fixation. It's modified and with also in our time we don't use this type of surgery. Okay, and also a couple of cases. Patient with 73 years old, and we made posterior fixation, and see one was more transpedicular fixation, and next clue we see here is smaller. We made pars fixation because we have problem with another too tiny. And also we use second technique, and that's why we don't have navigation. That's why fixation and next part. Here, 78 years old, also from fallen from a tree without neurological death, only complaints of neck pain. Right. There's also the C1 fixation. In C2 we use a pars fixation. Here we see. And also all these patients dismissed without neurological death. And also we work and years old was a vehicle accident. After admission, combined trauma involved head and neck. First was his head operation because of brain injury. Temporal craniotomy, and we use neck fixation because the patient was unstable. When we stabilized the patient, then we made a combined operation of neck fixation. We made C1 fixation, so cranioplasty with their own bone. Does anyone have some questions? No? Then it was a pleasure for me, and I hope we will see you in Georgia. And luck.
Thank you. Okay, thank you. Hello.
Hello, I'm ready.
Yeah, okay. Please continue. Please give your introduction and please continue the session.
Good evening from Vietnam. My name is Dung Trung Kiên from the Department of Neurosurgery, Singapore Hospital. Today, I'm very honored to be here for sharing my knowledge in neurosurgical disease with the other colleagues all over the world. Now I will share my screen now. Can you see my screen?
Yes, we can see your screen.
This is my presentation the name with the name outside in the management of intracerebral hemorrhage. Classically, injury from the ICH is separated into primary injury and secondary.
Some microphone is not mute.
Yes, yes,
Please.
Primary injury or the internal damage from the hemorrhage itself is related to mass effect from the internal hematome or hematoma expansion and hydrocephalus. The secondary injury is a result of the activation of injurious pathway, including inflammation, iron and blood-related toxicity, and oxidative stress. As you know, hematome expansion have been shown to be an independent predictor of increased mortality and poor outcome in intracerebral hemorrhage. Identification of an accurate and reliable predictor of hematome expansion in ICH patients is very important. Hematome expansion occurs early after ICH and the independent predictor of neurological deterioration, mortality, and poor functional outcome. A prospective of observation study in 103 patients with spontaneous ICH who had on baseline CT within 3 hours of onset and repeated CT at 1 and 12 hours after the baseline scan found that the subcutaneous hematome expansion occurred in 26% of patients on the 1 hour scan and in national 12% of patients on the 20-hour scans. Hematome expansion were treated among those who underwent the initial CT scan within 3 hours of onset and progressively decline at the time to internal scan were prolonged. According to the guideline for the management of spontaneous ICH in 2015, the high rate of early neurological deterioration after ICH is related in part to activating that may process for hours after symptom onset. Hematome expansion tends to occur early after ICH and increase poor functional outcome and death. Among patients undergo SCT within 3 hours of ICH onset, about from 29 to 39% have hematome expansion greater than 1/3 of internal hematome volume on the follow-up CT. The identification of patient at risk of hematome expansion is an active area of research. CTA and contrast-enhanced CT may identify patients at high risk of ICH expansion based on the presence of contrast within the hematoma, often termed a spotlight. The CTA spotlight has emerged in recent years as a potential predictor of hematome expansion and potential tool in guiding therapy in both research and clinical care. Multiple retrospective single-center cohort studies have confirmed that contrast interval passion and the spot size are potent independent predictor of hematome expansion. A higher spot size score is associated with risk of subsequent hematome expansion. The previous study confirmed a strong association between sports science and the development of expansion. Children study has examined the value of the sports science as a predictor of functioning outcome and short-term and long-term mortality. Similarly, the sports science score has shown to be associated with both in-hospital mortality and poor clinical outcome at 3 months. Secondary causes of SICH are generally excluded from sports science study because of reason different in pathophysiology and the relatively frequent need to surgical treatment. The search for effective treatment that improve outcome in patients with ICH continue to be challenging. Selection of patients at high risk for expansion has therefore been a strategy in recent trial researching in improved outcome. The challenge provides a potential role for the sports science and selection tool. With the sports science as strong predictor of it may be possible to identify ICF patients who are most likely to have poor outcome and treat them aggressively. In retrospective research from Kazuko Hota in 2014, the presence of the foci indicated the possibility of hematoma growth and unfavorable outcome. You can see in the table of the relationship between the presence of foci and hematome expansion on CT. Hematome enlargement was found on CT in 15 of 14 patients with foci and in 14 one without foci. The frequency of hematome enlargement were significantly larger in patients with foci than in patients without foci, with P below 0.001. Favorable outcome modified A modified ranking score below 2 at each chart were obtained in the four of 19 patients with foci and 37 in the without foci. The frequency of favorable outcome were significantly smaller in patients with foci than those without foci. That occurred in 17 of 19 patients with foci and 28 of 243 patients without foci and were significantly more frequent with foci. We have some skill to calculate the hematome expansion, inputting 9-point score for 24-point score, predict A score, predict B score. In this score, CTA score size make a key element. And what is the spot size? Identification of the spot size on CTA may help to identify patient at risk for hematome expansion. A spot size will confirm according to the following strict radiological criteria. Over one focus, a contact pooling within the ICH with an attenuation 120 Hosfin unit, discontinued from normal or abnormal vascularity attention to the ICH, any sign and morphology. In this study of Rwanda, the sensitivity, specificity of positive predictive value, negative predictive value for hematome expansion were 91%, 89%, 77%, 96%, and 8.5 respectively. In multiple regression, the spot size independently predicted hematome expansion. In the study from Armando in 2009, the author created spot size score including number of spot size, maximum ASEAN dimension, and maximum attenuation. For example, when a patient got 1 or 2 spot size in CPAs, he received 1 point. He got 2 points when his CPA had more 3 plus. The spot size score is obtained by adding the total number of points for the CPA. The risk of hematome expansion reached 100% when the spot size score would fall. This is the maximum score. The author found that over 3 spot size has ASEAN dimension over 5 millimeters and attenuation over 119 Hodgkin units were independent predictor of significant hematoma. And the spot size score predict significant hematome expansion in primary ICH. This is a research in the Journal of Medicine so that the spot size occur in 23.4% patient with spontaneous ICH undergoing CT scan. And the spot size will also the predictor of poor outcome at discharge and at 3 months. And the overall incidence of ICH of the CTA spot size in spontaneous ICH patient is subsistent. Spot size demonstrated a good diagnostic performance in predicting hematome expansion and were closely associated with the increased risk of death and poor outcome. A meta-analysis of 2019 input included 26 studies describing over 5,000 patients, which showed that the high area under the curve suggests that the spot size can predict hematome growth and mortality. For positive ratio and negative ratio for ICH expansion is 4.95 and 0.48. A recent study by Fancombe in 2022 confirmed that spot size correlated with larger hematoma, worse outcome, increased risk of hematome expansion, and need surgical intervention. A more significant percentage of patients with a spot size underwent surgical intervention. The presence of spot size corrected with the higher modified ranking score at the discharge. A patient positive with a spot size saw a trend toward longer length of stay in ICU and overall hospital stay. Sorry. The primary analysis included 2,020 patients from Predict-3R trial, so the median base ICH volume is 19.9 millimeters in the spot size positive group. The volume of ICH expansion were about 10 minutes in the spot size positive arm. All the patients in this study underwent CPA within 6 hours of onset. 30% were spot size positive. In patients with expansion, spot size were 51% sensitive and 95% specific for hematome expansion. Mortality at 3 months were 43.4% in CPI spot size positive group versus 19.6% in the CPI spot size negative group. The association between CPI spot size positive group and mortality remained significant in a sensitivity analysis, whether a patient lost to follow-up were assigned a modified ranking score of 0 or 6. Kaplan-Meier analysis relevant and early difference in mortality between CPI spot size positive and CPI spot size negative. These were retrospective analysis of consecutive patients in primary ICH who received CPI within 24 hours from presentation to admission for patient in 2021. The present spot size score were examined by the experienced neuroradiologist. In total, 66 patients met the inclusion criteria. There were only 9 persons who were positive for spot size. 2/3 of patients positive for spot size received the surgery, compared with only 1/4 of those negative for spot size. Regarding functional status, patients with spot size tend to be severely dependent in activity, daily living at WeChat, and were more likely have profound disability. All the patients who achieve the functional independence were negative for the spot size. This is the result from the other journal. Active intraoperative bleeding occur in 38 patients and were more common in patients with a spot size. A total of 60 patients met the composite endpoint of post-operative rebleeding or unsuccessful surgery, which were also more common in spot size positive patients. On follow-up CT, post-operative bleeding in need of the repeated surgery were identified in 5 patients, including 4 patients were spot size positive and 1 patient is spot size negative. In conclusion, hematome expansion is one of the most dangerous disadvantages of ICH. CPI spot size is the most effective tool for confirming the hematome expansion. The CPI spot size is associated with the presence and extent of the hematome progression. It should be used widely in practice to predict the clinical outcome of ICH patients. Thank you for attention.
Thank you so much, Dr. Duong. You have made a great effort to make this whole presentation. It's really very nice. Thank you so much.
Yeah. Thank you.
Thank you so much.
Now I will begin to continue my second presentation, or not?
Yeah, hello. Who is this? Yeah, hello, who is this?
May I
Yeah, hello, doctor.
continue my second presentation or no?
Yes, 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 please.
Yes. Oh, we give you all the records. Idea.
I did it, but I did not have. It's okay.
Yeah, because I want to see a meeting.
Really, check it, yes, and what did you say?
What is this?
The one I told you, this one I told you, this one is like this. This is like the other.
Don't worry.
This is sweet.
How much is this?
It's 150.
150.
Yes, maybe let's see, then we have money. Let's see.
No, I think if you want 150.
This is my second presentation about the chronic subdural hematoma. The chronic subdural hematoma is one of the most frequent pathology in daily neurosurgical practice and literature. It is characterized by pathological collection of blood between the dura and arachnoid, meaning the layer surrounding the brain. Despite the increasing prevalence of chronic subdural hematoma, class 1 and evidence regarding the management of DTZ is lacking. Management of DTZ include surgery, for example, craniotomy, twisting, birth bone, trephination, or endoscopic, and non-surgical approach, such as using steroid, tranexamic acid, or mid-meningeal arterial embolization. Theory describing the formation and expansion of chronic subdural hematoma had evolved over time. In 1857, Vinchurch used the first term of Parkin meningitis hemorrhage interna in reference to a scale of chronic subdural hematoma, and he believed that chronic inflammatory process were driving the growth of the new vessel and fibrin exudation. A more recent understanding of disease combine several elements of the period theory into a cycle of chronic subdural hematoma formation. The bleeding occurs from the dural border cell after 4 to 7 weeks of trauma. It leads to the formation of an inflammatory membrane and fuzzy nerve vessel that cause continued exudation of fat and blood over time. We know a lot of risk factor in chronic subdural hematoma. Trauma, mostly minor head trauma, is the most frequently caused for the majority of chronic subdural hematoma patients. There is a history of some form traumatic brain injury that occur weeks before the onset of symptoms. The trauma is believed trigger of chronic subdural hematoma. The elderly age are the high risk because of the brain atrophy and the bleeding vein are spread and has become more fuzzy than the younger. Some research have reported that at least 4 to 6 of 10 patients with chronic subdural hematoma take anti-thrombotic medication. Overshown after VPSN or dural leak are known factors which can result in chronic subdural hematoma. The leak most commonly occur due to iatrogenic causes involving intentional or unintentional trauma to the dural matter. a consequence of surgery or overdrain of CSF during lumbar puncture or CSF dam system. Injury associated with chronic subdural hematoma tend to be minor without any accompanying severe brain injury. The accumulation of blood within the subdural space occurs slowly over an extended period and under comparatively low pressure. The coexistence of brain atrophy in most cases and the slow formation and expansion of the hematoma allows the hematoma bridge to lack the sign without triggering neurological symptom. This symptom arises when the press causes hematoma lead to compression of the cortex and cannot be tolerated and compensated anymore. Patients with chronic subdural hematoma can be asymptomatic, have very mild symptoms such as headache, nausea, vomiting, or present with acute and grave symptoms including hemiplegia, seizure, or coma. The classification of chronic subdural hematoma based on the density on the non-contact computed tomography. A, the isodense, B, hyperdense, C, laminar type will define a hematoma that has a high density laminar structure running along the inner membrane that we consider it to consist of the fat blood originated from the hematoma membrane. These separate were divided hematome contain two components of different density, a lower density component located above a higher density component with a clear boundary line between them. Hypodense F radiation will confirm when the boundary were district with a low density and high density being mean as a border. G trabecular will define a hematome with inhomogeneous content with curvature high density separate treated by fibrous running between the inner and outer membrane on the low density to isodense background. The imaging of chronic subdural hematoma in CT were developed chronic subdural hematoma grading system to predict recurrent requiring reoperation after internal backbone surgery. This grading was built by the Norway authors and were published in 2017 at the Neurosurgery Journal. This grading has three components: density of hematoma on CT, volume of hematoma, and the volume of post-operative residual cavity. The minimum score was 0 with 0% of reoperation, and the maximum score was 5 with the rate of reoperation was 63%. The standard diagnostic tool for chronic subdural hematoma is CT. However, many studies continue the effectiveness of MRI. Based on the MRI finding, Goto classified chronic subdural hematoma into hyper intensity, iso or hypo intensity, mixed intensity, and layer intensity on T1 and T2 imaging. Unclear algorithm for management of chronic subdural hematoma were recommended. Trephination either by backbone or twist-ring is a treatment of choice for symptomatic patients. Craniotomy should be reserved only for symptomatic, organized, or solid hematoma. For the recurrent chronic subdural hematoma, if the risk of recurrence is low, still repeated trephination is simple and effective. If the risk is high, additional management such as embolization of middle meningeal artery may reduce the chance of recurrence. For refractory chronic subdural hematoma, it is necessary to obligate the subdural spread by lumbar or ventricular injection. Subdural peritoneal can be the last choice for this condition. This is some outcome of evidence-based review for outcome of contemporary surgery for chronic subdural hematoma. We have a lot of recommendation for irrigation, drainage, treatment of recurrent, and a system scoping review focused on the control this year in surgery treatment of chronic subdural hematoma was published last year in 2022 in Diagnostic Journal. So author list some subjects associated with surgical treatment. And this is the surgical method, including trephine, craniotomy, or endoscopic assisted in evacuation of chronic subdural hematoma. On a randomized trial comparing three popular procedures in treatment of chronic subdural hematoma, including Berg-Hole craniostomy, mini craniotomy, and twisting craniostomy. This study want to determine which the surgery technique for drainage subdural hematoma offer best result. This is the result of this study. Berg-Hole has 78 written 5% of good outcome and 5.1% of mortality in comparison with a twist ring has a great good outcome and mortality is 58.5% and 2.4% respectively. Mini craniotomy has 15.5% of patients that need reoperation and 4.8% of major medical complications. Although not reaching statistic significantly in the study, the Berg-Hole method offers the lowest recurrent rate combined with manageable complication rate and should currently still be considered as standard first-line treatment of chronic subdural hematoma. Twist ring can be offered to the patient as a first line in elderly person who would be suitable for local anesthesia. The chronic subdural hematoma recurrent rate after surgical treatment is high, with a reported recurrent rate as high as 25%. Over the past 7 years, with evaluation of neuro-interventional technique, middle meningeal artery embolization to treat the chronic subdural hematoma has been made as safe and effective strategy. The middle meningeal artery embolization have been shown to be effective, particularly in patients recurrent chronic subdural hematoma or patients for whom surgical intervention is associated with particularly high risk. This method may significantly reduce morbidity and mortality rate. This method is used both as an adjunctive treatment in combination with chronic subdural hematoma drainage for patients with surgical lesion and as a standalone treatment for mildly symptomatic patients. Such that the treatment decision algorithm has been reported by the author from the Baron Neurological Institute and have been modified in response to the past 2 years of collective experience with the procedure. Mid-meningeal artery embolization as a standard-alone treatment in patients with large hematoma and high risk for surgery. The combination mid-meningeal artery embolization and surgical evacuation in systematic patients may be optimal. Answer to such question will be clarified by completing the ongoing prospective trial in the future. Post-operative complication frequent rate and outcome of CTC, failure of the brain to re-expand and accumulation of the blood in the subdural space is 0 to 30%, seizure from 1 to 23%, intracerebral hemorrhage about 5%, post-operative infection about 2%, tension and pneumocephalus about 10%. In conclusion, chronic subdural hematoma represent one of the most frequent neurosurgical disease. It is generally accepted that in the presence of neurological symptom and radiologic finding, patients should undergo surgical evacuation. 3 techniques are effective at treatment chronic subdural hematoma patients, including both bone craniotomy, mini craniotomy, and twisting craniotomy. Mid-meningeal artery embolization are becoming a standard therapy in management of chronic subdural hematoma. Prospective multi-center study providing tip a recommendation for the unclear subject are much needed. Thank you for attention.
Thank you so much for the beautiful presentation, Doctor. Yeah, hello. Okay, we'll take the questioning session after this conference. No issues.
Yeah, thank you for the question from Dr. Gabriel Vargas. My opinion about the embolization of meningeal artery of premier treatment, I think that it is a correct and effectively method when your patient is elderly and have a lot of the trouble in medicine. For example, the heart disease, pneumonia disease, for example. Is it correct when your patient is elderly person or the recurrent patient? Thank you.
Thank you so
Yeah.
much, Dr. Ali Haider.
I
Okay.
want to re-ask. The problem is that we have a lot of endovascular specialists that wants to do for every single patient, no matter if we have deviation of the midline and things like that. They want to try endovascular treatment and embolization of the meningeal artery. So I think this is completely wrong. What's your opinion about that?
Yeah, hello, Dr. Ali Haider. You can present your session now.
Hello. Can you hear me fine? Yeah. Good afternoon, everybody. Thank you for providing me with the opportunity to present our study, the very first systematic review to explore post-operative dysgeusia after microsurgical resection for acoustic neuroma. The acoustic neuroma, a benign tumor of the vestibulocochlear nerve, presents with symptoms including hearing loss, tinnitus, and vertigo, and microsurgical resection remains the primary treatment approach, with various approaches available, but it carries the risk of post-operative complications. While hearing loss and facial nerve dysfunction are well documented, taste disturbances, particularly dysgeusia, they represent an understudied yet potentially significant post-operative complication. A significant knowledge gap existed in the literature regarding the prevalence of post-operative dysgeusia following acoustic neuroma resection, despite its potential impact on patient quality of life. And this study therefore aimed to address that knowledge gap by providing a comprehensive analysis of dysgeusia rates with the goal of informing both preoperative counseling and postoperative care strategies. The primary objective of this study was to determine the overall pooled rate of postoperative dysgeusia following microsurgical resection of acoustic neuroma. Additionally, as a secondary objective, the study aimed to calculate the rate of postoperative dysgeusia stratified by surgical approach, specifically examining the retrosigmoid, translabyrinthine, and subtemporal approaches. The study also aimed to explore potential sources of heterogeneity across the included studies and assess the quality of the available evidence. Furthermore, we sought to identify gaps in the current literature to inform clinical practice and provide directions for future research. Our search strategy involved creating multiple databases, and the search period covered database inception till May the 16th of this year. The inclusion criteria for our study were primary studies involving patients with acoustic neuroma who underwent microsurgical resection, and those that reported rates of post-operative taste disturbances. We excluded those studies that involve surgical or open surgical treatments only. And we excluded publications with duplicate or overlapping cohorts. Data extraction was performed manually, capturing variables such as patient demographics, surgical approach, and disclosure rates. Unpublished data was requested from the authors where necessary. We assessed the quality of the included studies using the minors analysis, with scores ranging from very low, that's less than or equal to 6, to high, between 19 and 24. For statistical analysis, we employed a random effects model of proportional meta-analysis. We assessed heterogeneity using the I-squared statistic, and subgroup analysis were conducted based on sample size, study design, and geographical location. Moreover, publication bias was evaluated using Aguirre's test and Becker's test. The search strategy implementation yielded 40 publications, and upon excluding 32 studies secondary to indicated reasons, 8 studies were included in the review. Our meta-analysis included a total of 2.4K patients with a mean age of 49 years. 48% was female population, and in terms of surgical approaches, 6 studies explored the retrosegment approach. 2 studies adopted the translabyrinthine approach, whereas only a single study reported adoption of middle fossa approach. When 2 studies did not specify the approach. The study period ranged from 2008 to 2023, the geographical diversity spanning Southeast and East Asia, Europe, and North America. We calculated the pooled rate of post-operative disclosure of 23.7%. That indicates statistical significance. However, we observed substantial heterogeneity across studies. Still, we can conclude that almost 1 in 4 patients experienced post-operative dysgeusia following microsurgical resection of acoustic neuroma. We did not detect any significant publication bias in our analysis of the overall rate of post-operative dysgeusia. Upon running a subgroup analysis, we found that larger studies and case series tended to report low rates of dysgeusia, with significant geographical variation in reported rates. The dysgeusia rate for the retrosegment surgical approach came out to be 18.8%, with observed substantial heterogeneity across studies. We can conclude that nearly 1 in 5 patients experienced post-operative dysgeusia following microsurgical resection via the retrosegment approach. We detected potential publication bias in our analysis for the secondary endpoint. It is imperative to note that we had insufficient data to perform a stratified analysis for the other surgical approaches, including translabyrinthine or middle fossa approach. Our findings highlight the clinical significance of post-operative dysgeusia, and that appears to be a commoner complication than previously recognized following acoustic neuroma microsurgical resection. Taste disturbances can significantly impact a patient's quality of life and should be accounted for in post-operative care plans. These results underscore the requirement for 3 key strategies. First, preoperative counseling should be undertaken to ensure that patients are aware of this potential complication. Second, intraoperative techniques and strategies should be aimed at minimizing damage to the caudate lymph, which is closely associated with taste perception. Moreover, the development of standardized post-operative management protocols should be implemented specifically for addressing taste disturbances post-operative in this patient population. Our meta-analysis is the very first of its kind to specifically focus on the post-operative dysgeusia following acoustic neuroma microsurgical resection. Few studies have reported varying rates of this complication. For instance, a study found a 100% resolution of taste disturbances within 6 months, whereas another study reported a 10% of the patients experiencing persistent dysfunction even after 2 years surgery. In contrast, our findings highlight a higher prevalence of post-operative dysgeusia than commonly recognized in the literature. This discrepancy may be due to our comprehensive meta-analytical approach that pooled data from multiple studies and provided a more robust estimate of the overall rate. Several potential mechanisms may contribute to the development of post-operative dysgeusia in this patient population. manipulation of the choroid enough, which has an independent association with the surgical field, can lead to micro damage during dissection and/or tumor infection. The specific surgical approach employed may impact the risk of diffusion. Our data suggests a high risk with the retrosigmoid approach, particularly for larger CUS with grade 3 and 4 tumors. Our data on other approaches, such as translabyrinthal middle fossa, are limited, and that highlights the need for further research. Moreover, tumor size itself may play a role in studies, reporting a significant increase in diffusion rates for CUS grade 2 and 4 tumors. Finally, postoperative inflammation and edema in the surgical field may contribute to the temporary test disturbances in the immediate postoperative period. Our meta-analysis has several limitations. Firstly, the included studies were all rated as moderate quality on the minor scale. That indicates potential for bias in the individual studies. We had limited data on specific surgical approaches. With the lack of data on two of the microsurgical approaches, and this restricted our ability to compare diffusion rates across all commonly adopted surgical techniques. We observed high heterogeneity with aspect statistic values greater than 97% for both our primary and secondary endpoints. And thus, significant variability across studies limits the generalizability of our pooled estimates. Therefore, it is important to interpret our findings in the context of these limitations. We also detect potential publication bias in our analysis of the diffusion rate for the retrosegmented approach. And that publication bias may lead to either an over or underestimation, may lead to rather an overestimation of the true prevalence. Another limitation was the variability in the assessment and reporting of the diffusion across the individual studies. This lack of standardized measure could lead to inconsistencies in how test disturbances were evaluated and reported. Studies that relied on patient self-reporting may be affected by recall bias, potentially leading to an over or underestimation of diffusion rates, as patients may not accurately recall either the severity or duration of the test disturbances. Our key takeaways are that post-operative diffusion is a common complication following acoustic neuroma microsurgical resection. Specifically for the retrosegmented approach, 1 in 5 patients may suffer from this ailment. However, it is important to note that we observe significant variability across the different studies. Based on these findings, we have several recommendations for clinical practice. The risk of postoperative dysphagia should be included in preoperative counseling for patients undergoing acoustic neuroma microsurgical resection. Intraoperative strategies should be implemented to minimize potential damage to the choroid tympani, which is closely associated with test perception. Postoperative care should incorporate routine assessment of test function to identify and monitor patients affected by diffusion. We recommend the development of multidisciplinary management programs involving neurosurgeons, otolaryngologists, and other relevant specialties, as well as allied healthcare professionals, to provide comprehensive care for patients experiencing test disturbance after microsurgical resection for acoustic neuroma. Our meta-analysis has identified several key areas for further research in the field. There is a need to investigate diffusion rate specifically for the translabyrinthine and September surgical approaches, as our data was limited in that regard. The development of standardized, validated measure for assessing test dysfunction would greatly improve consistency and comparability across studies. Long-term follow-up studies are warranted to better understand the persistence and potential resolution of dysphagia over time in this patient population. Research into intraoperative monitoring techniques for test function, as well as the evaluation of postoperative interventions such as steroids, could provide valuable insights into prevention and management strategies. Furthermore, exploring the potential impact of surgeon experience on diffusion rates, as well as the relationship between tumor size, location, and diffusion risk, could inform surgical planning and patient counseling. In conclusion, our findings highlight the need for increased attention to postoperative diffusion in the management of acoustic neuromas. Addressing this common complication has the potential to significantly improve patient outcomes and ultimately quality of life. Thank you for your attention. I would be happy to take on any questions. And for those interested in contributing to our research and our pursuing systematic reviews in neuroscience, please feel free to contact. Thank you.
Thank you so much, Dr. Ali Haider, for your presentation. Thank you so much. Yeah, welcome everyone. Hello, Dr. Nicholas. Hello, Dr. Song Kunifan. Hi.
Hello. Hi. Hello,
Hi.
everyone.
Hello, everyone. You
Yeah.
people have really missed the beautiful presentations, and you are attending the 6th presentation, right? You really have missed some presentations like from great speakers named Bahadin Hussain and Dr. Damian and Dr. Gabriel, of course. So you really missed some of the good presentations. And Dr. Ali Haider have also given a beautiful presentation. So, okay, who is next? I think, give me a second. Naka. Sentana. Yeah, I would like to call Dr. Ahmad Abdul Wahab. Are you present? Okay, okay, okay. Dr. Nicholas Sirmos, are you present? Could you hear me? Dr. Nicholas Sirmos, could you hear my voice? Sorry, hello, Dr. Nicholas. Okay, Dr. Utsav Shrestha, are you available to give your presentation?
Hello, Miss Jiz Calvin Lan.
Yeah.
I know
Yes.
I'm the last one, but I have prepared already.
Yeah, of course, you have been here from very long time and you have already listened to the previous conferences.
Yes, it's very good, and I learned a lot of the knowledge and experience from the professor of the world. It's a good chance, and it's a good.
Can you hear me?
Okay. Sorry to interfere. Dr. Nicholas. Can you respond me, please?
I have a small problem with microphone. Please give me 1 second. 1 minute, please.
Yes, sir. Yeah. So, Dr. Song, we can make your presentation after the presentation of Nicholas Sermos, because we asked him to present first. Is that okay? Okay, I'm talking to Dr. Kune Fang from China. Hello, Dr. Song.
Okay, no problem. Okay.
Thank you. Thank you very much for understanding.
Can you hear me, please?
Yes, we can hear you.
May I share my presentation?
Yes, yes, please. Hello, Dr. Nicholas. What happened? Okay. Okay, we can see your screen.
You want to take a break? If the next speaker is not available, Geet.
The speaker has already started his screen sharing, but I don't know what happened to him. Could I call Dr. Nicholas? Are you available to share screen, or we shall wait for some time? Could you hear me,
Can you
Dr.
hear
Nicholas?
me? Can you hear me right now?
Yes, we hear your voice.
Okay. Thank you
But we
very much.
don't.
I have a small problem with microphone. I apologize about that. It is a great pleasure to be with you, my dear friends, all of you. I will make share screen and I will present my presentation. I'm Nikolaos Firmos from Thessaloniki, Greece, and I will speak about sports-related concussion. Is it possible to say to me that you can show my presentation?
Yes.
Okay, thank you very much. My presentation is current concepts in sports-related concussion. As I said before, I'm Nikolaos Firmos and I am consultant neurosurgeon in Thessaloniki, Greece, and also a European Association Neurosurgical Society's active member. If we can speak about sports-related concussion, we have to make an introduction. The concussion is the type of traumas that interferes with normal function of the brain. When the brain is rocked back and forth of twisted inside the skull as a result of the blow to the head of the body. It is very important the understanding of the sports-related concussion, and this is a concept that it is in continuing evolving in recent years. We know that all the athletes, both amateur athletes and also professional, are particularly vulnerable to the effects of a concussion. We have also to respect and to deal about the health-related problems and the health-related quality of life and the quality of life of these elements. Once considered little more than a tin on the head, it is now understood that the concussion has the potential to result in a short or a long-term changes in the brain functions with the consequences in the overall health. Who doesn't understand, who doesn't know the history, and does not respect the history, has no possibility to have a good present and also a good future. We can see the acrotiri boxer fresco discovered in 1967, when we have an fresco depicting two young boxers of Bronze Age, 1,700 years before Christ in Santorini, Greece. And this is the evidence that the ancient Greeks knows that the athletics and knows also the traumatic brain injuries that kind of athletics must provocate in contact and also in compact injury. Boxing in that area, it was also compact and also contact injury. If we are going in the history, we can see Celtics against Range Rovers in Glasgow, in Scotland, that we can see the young goalkeeper Thompson hit by the center forward of the adversary team, and then he died of brain trauma. Much more knowledge about traumatic brain injuries in the sports. We know from this guy, I have the privilege to meet him, was Sid Watkins. Dr. Sid was for 40 years the head doctor, the head medical doctor of the Formula One racing championship. And this we can see with the Ayrton Senna, great pilot of the Formula One, that he died by traumatic brain injury in 1st May of 1994. What is a concussion? Sometimes we can also use the terms ding, call, bell, ringer. But if we can speak about concussion, is the minor head injuries and thought to be a normal part of the sports. A concussion is caused by a bump, blow, or jolt to the head or of the body. But basically, any force that is transmitted to the head causes the brain to itinerary bones around of twist within the skull, potentially resulting in a concussion. The American Society of Sports Medicine make a position statement about concussion in sport and gives the definition that the concussion is defined as traumatically induced transient disturbance of brain function and involves a complex pathophysiological process. Concussion is a subject of traumatic brain injury, which is generally self-limited and at the less severe end of the brain injury spectrum. Caligaris was an Italian sports physician. He designed the three main mechanisms of traumatic brain injuries during soccer or football in the European continent and soccer in American continent. There is this distinguish of the name because our American friends or when they are speaking about football, they mean the American football. We have head with head, angle with the head, and in portiere goalkeeper when they are trying to reach the soccer ball. The Americans have a very good statistics, and they show that the mechanism of head injury in soccer in percentages, head to head is the most common fact
అడ్వాన్స్ ఇచ్చామని
in
చెప్పారు. అది రేపు రిజిస్ట్రేషన్ స్లాట్ బుకింగ్ చేస్తే పంపించారు. రేపు 1 గంట
there is
కల్లా
a small noise. I don't know what about. Head to head, head to elbow, head to knee, and head to ground is the following categories. Many changes we have in combat sports, as we can show, and also in contact sports, we have some cases. We don't have not to forget that sometimes we have violence in sports, and some traumatic injuries are causes about the main causes are the violence. The pathophysiology is very important. What exactly happens to the brain during a concussion is not entirely understood. And sometimes we have complex injuries that we have to investigate and also sometimes to operate. The pathophysiology mainly is the sudden movement of the brain causes stretching and tearing of all brain cells, damaging the cells and creating chemical changes in the brain. The diagnosis is very important. Nowadays we have CT scan, 3D CT scan that we can see the fractures. MRI and X-rays also are available in our armamentarium in order to make an accurate diagnosis. The recognition is very important, and the good recognition, the appropriate recognition leads to the accurate and the appropriate management. And we don't have to forget that the traumatic brain injuries can cause even death of our sports men and sports women. The symptoms, the symptomatology is very, very big chapter. We have headache, nausea, balance problems, vision problems, ENT problems, hear, noise, and all the things, feeling problems, concentration problems, and confusion. Sometimes we have all of this. Sometimes we have some of these symptoms. The important notice leads to an appropriate healthcare professional solution in this problem, and the neurosurgeon also followed by the neurologist, the radiologist, and sometimes the psychiatrist, and also the physical medicine can lead to a good diagnosis and a good and accurate management. The signs observed by parents, friends, teachers, and coaches are all these that you can see. Also the teachers, when we are speaking about young athletes, and also the coaches must be trained and good and get also training about how to manage the traumatic brain injuries. We have a 4-step action plan. Remove the athlete from the play, ensure that the athlete is evaluated by a healthcare professional. The information of the athletes is very important, and they keep out the athletes out of the injury before it was examined by a healthcare professional. It is very important. Signs, symptoms, and behaviors are very important after a bump, bump, or joint, head-to-head traumatic brain injuries, and all athletes must know that they should never try to cough out a suspected concussion, and the risk of such behavior must be emphasized to all members of the team as well as the coaches and the parents. If an athlete returns to activity before fully healed from an initial concussion, the athlete is a risk to repeat concussion. We have to be very careful about it. A repeated concussion must be dangerous and sometimes must cause even severe traumatic brain injury and even the death. In the athletes of box, we have the repeated concussion. Traumatic brain injury followed by traumatic brain injury is the mechanism of the repeated concussion. The cognitive rest is very important about the athletes when we have both amateur athletes and much more when we have professional athletes. The short and the long-term memory, concentration, and organization must be carefully analyzed, recognized, and carefully recognized and managed by the new neurosurgeon, neurologist, psychiatrist, radiologists, and physical care medicine, and also the sports physician. The rest is essential to help the brain to heal. All the symptoms must be allowed, increase of the computers, cell phones, video games, and all the rest. The return to play is a very big question. No athlete should return to play or practice on the same day. An athlete should never be allowed to resume physical activity following a concussion until the symptoms are free and given the approval to resume physical activity by an appropriate health care. This is the 5-step program, progressive physical activity program, the so-called PPAP. Light aerobic exercise, moderate aerobic exercise, no contact drills, full contact, and full gameplay. This is personalized through to the sports activity. The consensus statement of concussion sports in 2012 give the graduated return to play protocol, no activity, light aerobic exercise, sport-specific exercise, no contact train drills, full contact plays, and return to play. It is very important. What to do in the emergency in all the things? The emergency care is very important about our athletes, and all the sports physician and all the physician has to be trained in order to accurately evaluate the brain concussion. The return to play, the so-called RTP, or practice on the same day of the concussion, no athlete should return to play, and the return to play should follow a stepwise protocol with provision of delayed return to play based upon return of signs and symptoms. This is the concussion modifiers through to the symptoms, signs, sequelae, temporal, threshold, age, comorbidities, medication, behavior, and sport. This is a very complex fact to understand. You once have to face repeated trainings in order to understand this concept, and he has to evaluate the sports physician for many years in order to understand and to practice all this. We do not have to forget that the management of concussion in athletics scenario of sports medicine that continually evolves. And this is some of the preventive rules that in the United States we have. The strip around head where the most impact occur, and some technical characteristics of this stripe. The ECOSEP is the European College of Sports Physicians, has also a training program, the so-called Sports on Field Trauma Emergency course, that a physician can also be trained in order to face all these traumatic problems. This is the SCAT, the Sports Concussion Assessment Tool, adapted by FIFA, the Olympic Committee, and this is an assessment tool in order to understand the concussion in the field. It is through the cognitive and physical evaluation and through to the symptom evaluation and moderation. Finally, we have the UK government concussion guidelines for not elite, for amateur athletes, and we have also the 6-step program from relative rest for 24 to 48 hours, gradually introduce, increase tolerance, return to study, return to normal work, and return to sports competition, not before day 21 is very important. And the message is that everyone involved in the care of athletics, including coaches, trainers, referees, administrators, and other school personnel, as well as the athletes themselves, has to be educated regarding the serious notice of the concussion. Special care to the young athletes and special care to the professional athletes, because an integrated team is essential to both minimize the risk for concussion. Imagine how responsible you are if you have a football league in English Premier League, an athlete that they spend much more money in order to get in the team. This is a very important thing. Thank you very much, and it is very important here to be with good friends and very good physicians around the world. And I have to make my compliments to the organization, to my friends that they support my application in order to be here. And I hope and I will work also in the future for future workshops and future webinars. Thank you very much. It's a great pleasure and great honor for me to be here with you, dear friends. I apologize that I wasn't able to open my microphone before, because today I'm on duty in my hospital. And thank you very much. Great honor to be here.
Thank you very much, Dr. Nicholas. Thank you very much. Can we go to the other presentation? Dr. Song Kunifang, are you there?
Yes, I'm here. I'll open the web video. Hello, everyone.
Yeah, fine.
May I share my screen? Can I share my screen here? Hello, Miss Jates. Hello, Miss Jates. Anyali? Did you see my screen now? Hello?
Yes, hello.
Can I begin my topic?
Yeah, yes.
Okay. Hello, everyone. I'm Dr. Song Kunfeng from Southern People's Hospital of Henan Province, Zhengzhou, China. It's a very great honor to present the international webinar for neurosurgeon and spine surgeon. Of course, I'm a spine surgeon, so today's my topic is the ultimate secret of harness UBE minimally invasive surgeon. Okay, first I will introduce my hospital. My hospital located at the middle of China, about 700 kilometers from Beijing and 800 kilometers from Shanghai, and in the middle of China. So this is my hospital, and this is my center in the vertebrate disc center, and my hospital finished more than 100 million cases from 2019 until 2024. So the minimally invasive surgery is my major work in our hospital. Welcome to China to visit our hospital. Okay, first I will introduce my work about advancement of spinal endoscopic technique from 2020 year, we only do the PALD of the ID for hysterectomy. We call that Young's technique. And we could maybe say that one point technique. And until 2040 year, we do the ULBD for laminectomy. Is the earlier institution for our hospital to do this technique. And when we arrive at 2016 year, we do the UBE for cervical span and thoracic span stenosis. We call that 3-point technique. When we arrive at 2018 year, we can do the endoscopy for lumbar instability or spondylosis. We call that 4-point technique. From 2019 year, a pandemic a lot of world. So, but the UV technique come to our life. So we learn the UBE. So we can do UBE, ULBD for cervical, thoracic, and the lumbar stenosis, and we can do UBE, TLIF, and the create the new technique MOUA, ACDF, and ACCF. This year, we can update the UBE technique. We can do the blindness UBE. Means that the field UBE, we call that 6-point technique. Maybe in the future, AI assistance speak technique, Arabic navigation assistance speak technique will come to online. We have 60 option to overview. The first is definition and some definition of view. The prerequisite for mastering view and the core element and mastering view. The 4 is the key step to mastering blindness UBE. The 5 is other factors for mastering blindness UBE. The last one is topical case, summary, and tips. So we can see the definition. In my opinion, except for incision bleeding, more than 95% of the anesthetic operations have a clear field of view without red screen. The anatomical structure recognition is 100%, and the amount of the anesthetic bleeding is negligible. Some inefficiency minimize the risk of surgical complications and improve surgical safety. Minimize ineffective operations and improve surgical efficiency. Minimize surgical time and facilitate rapid recovery of patients after surgery. The 4 benefit the training and the teaching of UBE technology. And benefits the standardization, regularization, refinement, and the intelligence of UBE technology. Last one is benefit the integration and the innovation of UBE technology for tools. Prerequisite. 1, the first one is equipment and cost. The 2 is team, their staff, including necessary assistants and nurses. The 3rd is basic skills of the surgeon. The 4th is operation volume. The 5 is preoperative planning and design, including positioning, marking, and incision. The last one is the surgeon's mentality and personality. So we can see the first one, improvements and tools. You have to earn these improvements and tools Imagine implements like source reliable cables like this picture. The next is teamwork, especially your staff is important for your surgery, especially necessities. Mention deep muscle relaxation and low and stable blood pressure throughout the operation according to the duration of the operation. The third is fix the first assistance, both an assistant and a best partner, holding the mirror and holding nerves. The last one is the instrument nurse, familiar with surgical procedures, UV instruments and certain operation habits. So I say the safe and efficient UV surgery cannot be separated from teamwork. The basic skill of the policy practitioner. The first one is neurosurgeon economic anatomy, anesthetic anatomy, surgery careers, open or anesthetic surgery experience. The second is adapted to hand-eye separation operation, adapted to single-hand meriscope, single-hand laminar rangers, 100-degree training. The third is standardized surgical operation. Four is all operations are away from the Duramed nerve roots, including touch, clamp, bite, bone, physical. Yeah. Each step of the operation is performed under visualization. Removing yellow ligaments nuclear purposes, parting protruding vertebral disc, and the climbing of collecting fats, tissue, burning, bleeding point near the dural mat, chiseling the dural bone of the nerve roots. One is surgeon value. From the 2018 to 2023, as we have finished the more than yes, in many cases, especially after the pandemic, we have finished the 2,000 cases every year. Yes, the endoscopic surgery performed 78.8%. So in Chinese word is practice makes perfect. So you have, China have many people and many patients to practice. Five is pre-operative planning, positioning, marketing, decision. You can see this picture. Including the surgical the arm skin, yes, and every patient we draw the markage on the skin. The five is the pre-operative planning. Yes, so this is we need 3 needles to put the middle of the span and the disc level and the viewpoint and the work point. The last picture is when we insert the skin, we put the metal in the build the work and the view photo. The sixth is the surgeon. The surgeon is mental mentality and the personality. The end of the surgical quality is character. So surgery reshapes character and the culture affects surgery. When a person's basic skills, specialized knowledges, and specialized skills matter, culture will have a great impact on surgical quality. Therefore, The end of the surgical routine is practical. The core elements we have 4. One is non-invasive, minimally mini-invasive concept. 2 is patient blood pressure can understated pressure. In irrigation, water pressure, muscle relaxation, maintenance. The 3 is the hemostasis throughout the process. Yes, throughout the whole process. The 4th is both hand to the coordinate stable vision. Yes, I think the 4th is very important to stable the vision to do the procedures. The one non-invasive or minimally invasive concept, micro-invasive treatment of muscle and soft tissue. The 2 is the micro-invasive treatment of bone structure, operation details when removing the yellow ligament. And the non-invasive or micro-invasive treatment of nerve spinal cord, operation details when handling the vertebral disc, operation details when handling in the vertebral space and the terminal cartilages. Operation details when inserting filling devices. Yes, every step to over the non-invasive, minimally invasive concept. The patient blood pressure can hydrostatic pressure, leverage water pressure, muscle relaxation, maintenance, and this step and every details is very important. Control hypertension, maintain basic perfusion volume 19 and 16 millimeter Hg. Can handle static pressure, smooth water flow without vortex, UBE retractor half cannula full vascularization. Irrigation water pressure, watch bag suspended to 7 to 100 centimeter above the surgical field. Maintenance of muscle relaxation, maintain deep muscle relaxation throughout the whole process. Next slide. To handle the coordination, stable vision, have 3 details options. That one is keep the length 1 to 1.5 centimeter away from the target during the whole process. The 2 is keep the same angle and the depth each time the instruments enter the operation channel into from muscle memory. The 3rd is using diamantic grinding pad as much as possible when protein bone tissues. The key steps. 1. Pay attention to the development of the initial time in your technology. What is changing not related, so we can put the materials yes to the decision, so we can do another tube and exchange wash and remove the clot. The second is expand the scope of the initial time. The third is patient. Hello? To primary statistics of every tiny bleeding point or area. The fourth is attention to decompression sequence. Factors that I can make every operation bloody. The second, if there's enough patients to do every detail well, in mental endurance and hesitance with The third is carefully try to change the ability to increase the operation of the vehicle at running before climbing and staging vehicle operation. The fourth step is step will follow slow to pass the first decompression from L1 to S1, and then you can do the L4 and then from L4 to L5 S1. The 5 is paying more attention to and work the UV operation line broadcast the zone of the cerebral hospital and the online public welfare academic activities of UV at every Tuesday. Okay, we can. I can share 5 cases, 5 cases to improve my opinion. That the one is mini open big assist ACDF. We call that MOVA-ACDF. We know that ACDF is the first product on 1953 by Dr. Robert Rosen. Then until now, the anterior cervical discectomy, disconversion, and the fusion is still the gold standard for the treatment of the CSM or CSR, right? Cervical spinal disease, a spinal cord type. The case 1 is the man, 38 years old. The problem is at C67. We can see the X-rays from pre-op and the post-op. Is we can do the ACDF probe with the zero P. Yes, with zero pH. This is the MR pre-op and the post-op, and we can see the cervical cord with the pressure seriously, and after the surgery, the canal is extend more. This is the CT scans after the surgical. We can see it's very enough of the space, the cross space. You can see the details. Yes, the left is skin incision. The right side we can have the plasma muscle. The incision is only 2 centimeter. It's very small and invasive, minimally invasive. Next, with separation of the low fascia and both the detection of the front of the vertebrae and the exposure of prevertebral fascia and prevertebral fascia incision. Yes, all the process, no blooding, you see. Is the precision needle placed in vertebral body, and from the PR scan to make sure the teeth is and retrospect hope to expose the surgical field. Then we can part in the annular fibrous wrapping the intercalated disc. Yes, this step we are in the air medium and then grab the posterior of the edge of the vertebral body, scrap to the uncoverable joint on both sides. Then this step we put the water. We put the camp in the water. As we enter the field of vision and water medium, and use power drilling to remove the posterior edge of the vertebral body. You can see if a small bleeding, we can use radio frequency hemostasis and use bone wax hemostasis. Then cut the posterior longitudinal ligaments, completed compression on the right picture. Yeah, it's very good and no blood and very safe. The proceeding of the upper and the plate and the prescriptions in the inferior in the plate. Okay, next we can put the cage in the. Next, yes, we put the camp out of the water and verification and the water and air medium microscope place the field mode. The last step, we placement the fielding cage and the screws, and the fielding cage is placed on the right picture. Okay, the case 2 is C3 for MOE-ACCF. You can see this picture of the patient CT scan. It's very serious of the C3-4 from the pre-operation CT scan, and the channel is very narrow, and the cornea, the core of the pressure very yes, very serious in the pre-operation MR. So the procedure, we can see the picture and the water medium is drilling in this step. So you can see the word and the picture. The drilling is very safety and yes, bloodless. Okay, we use the variable radio frequency to hemostasis, and then the post graduation pre of also feel the posterior longitudinal and the ligament. The last is the way you use the kerosene to yes, to fill floating also feel posterior longitudinal ligaments, and remove and the probable free floating the also feel the posterior longitudinal ligament. The last one, yes, that's the one. The left is in the water medium, the right picture is in the air medium. This is the decompression completed, complete the removal of the occiput posterior longitudinal ligament. Yeah. after surgery, we have the X-ray and the CT scan. We can see the yes, the image is very perfect, and the MR is also very good, and the cornel, the CRS cornel, and the area is extended enough. Yeah. The case 3 is thoracic span 9 to 10 UDE ULBD. Some professors call that over the top. Yes, UBE. You can see the image of the MR pre-operation and the post-operation. Yeah, the decompression is enough, and the pre-operation drama is very yes, serious, and the both these patients have both side weakness or numbness and the low back and the back pain. And this is the CT scan, preoperative and post-operative. We can look to the left side. We can remind to the facet joint and keep the thoracic span stability. Yes, this is the digital CT scan. From Sandy, we in resolution we can see the hole in the back is very small, and the facet remains more. And the picture of the video, we can see with the whole process we use drilling from head to the from head to the peritoneum. During the SP lateral osfield ligamentary flabrum lateral layer by layer. Okay, the case 4 is L345 UBE ULBD. It's for lumbar stenosis. This is the case of the MRV pre-operative and post-operative. Yes, we can see the stenosis is very serious after surgery. The decompression is enough, and the canal is extended more. And the syndrome of the patient was disappear. Post we can we do the first step. The first level is the L45, and this is the position. And then finish the profile. We put the drill, and then we switch the view portal to work portal. Yeah, and create a new incision for view portal. This is the image of MR and CT scan from pre-operation and post-operation. We can see the lumbar scanner is very narrow, and the post-operation is very good, and the span core is enough. This is the level 3, 4, 5. The last one is the L34. Okay, these three this video we can see it very clearly and no bleeding. The left is the cranial, the right side is caudal. Is we use radio frequency to hemostasis. It's the end of the surgery. We can see both sides of the urethric. Yes, we proceed, and the treatment is very enough. We proceed off the top. The left side is the cranial, the right side is total, and the space extent is enough. So we can see the next CT scan after surgery. The both side facet joint protect enough. So we do a lot of these patients. The next case is L45 UBE leaf. We can do UBE leaf or 3 and leaf. This patient is female, 50 years old, and he has L4 3 degrees spondylosis, and this is isthmus type. Yes. From the X-ray scan, we can see, yes, it's very serious, and yes, his both sides the isthmus type broken. This is the CT scan and the MR scan pre-operation. We use the UBE LPD and transfer to UBE LPD. Yes, we stand the left side of the patient to do the both side laminectomy. This is the position of the drawer, the position in the scan before operation. The first we can screw first. Yes, this is the CTR, this is the X-ray in the theory. So we can stand the right side at the patients and to the left. You see the position. And yes, we can use the screw mostly from the cranial to find the isthmus and the release and remove the bone and the ligaments. They expose the extend root, relax the extend root of the left and the transfemoral of the left side. Then we can do the right side. This is left, this is right. Is the CR scan in the operation. Yes, we can put a screw in the left side and finish the right side, the UV decompression. We can find the right side of the SAP and the ASP, and this the middle of the space. We can use glue to open the disc space and relax the right side extend root. When we in the water, medium, we can see the disc space clearly and no bleeding. After remove the disc purposes, we can put the mold, in the disc space and extend the space of the disc We can use the CR scan to see yes the spondylosis from 3 degree to 1 degree. Then we use the left yes with the bar in the left side and put the screen, fix the screen so the 1 degree almost recover better. So we can see the right side is disk space and put the cage in space. And after that, we can check the right side, the L5 knob root and the L4 knob root. The last, yes, we see the scan, the CM scan after the surgery. Is a CT scan. So, to the whole message, the primary UB minimally invasive spine surgery has become one of the most important minimally invasive surgical method in the spinal surgery because it is born for diagnosis and has a gentle learning curve. More and more spinal minimally invasive surgeries are flocking to it. Although UB technology is simple and easy to learn compared to other minimally invasive surgery, for example, unilateral uniportal endoscopic surgery. The red screen, the dura novel chamber, postoperative infection, or red vision of postoperative symptoms, or poor postoperative result of often occur. Blindness UBE minimally invasive surgery has taken this minimally invasive technology to a new level. The above mentioned related to complications will hardly occur, thanks to the clear field of vision, high resolution anatomical structure, and the standardized operating procedures provided by UB technology. In the future, blindness UB in minimally invasive spinal surgery may become the gold standard or surgical guide for the treatment of degenerative spinal stenosis and the local space occupying lesions of the spinal canal. The last tips are yes, strict needs before surgery, skilled during surgery, intelligence after surgery. In Chinese word is 言于术前，精于术中，勤于术后。Strictness before surgery refers to strictly grasping the indications for surgery, ensuring the necessity and the feasibility of the surgery. Skilled during surgery refer to mastering surgical technicals with great skill to ensure the success of the operation. Diligence after surgery refers to paying close attention to the patient's recovery situation and ensuring that they receive timely and effective rehabilitation care. These three links are closely connected, mutually influential, and indispensable. Thank you for your attention. This is our contact detail, and there are 2 free links of our hospital. Every month we held the full endoscopic spine surgeries salon and the UB endoscopic spine surgery salon. If everyone have no internet barrier, you can save this link. Repeat it 3 times because it's very important. Save this link. You can from this link see the surgery, the whole surgery from our hospital every month. If you have any question, and please hesitate to contact with me. Thank you so much. That's all. Hello. Hello, Miss Jess. Are you there?
Hello. Thank you. Thank you, Dr. Song. Your presentation was really very nice.
Hello.
Yes, hello. Could you hear me? Yeah, hello. Could you hear me? Hello, Dr. Song. You have muted yourself, I think. Couldn't able to hear you. Hello?
Did you hear me?
Yeah, fine. I was saying that your presentation is very nice. Thank you so much for attending. Sorry, we can't hear your voice.
Thank you so much. Yes, yes. Thanks again.
Yeah, hello. Our next speakers haven't joined yet. We should wait for 10 to 15 minutes to get them joined. Yeah, hello. I don't know why everyone is kept muted. I can't find out the reason. Dr. Baha.
So I mean, regarding the presentation, Dr. This is a very nice techniques that I would say for the ACDF, we are still capable to do a smaller incision and achieve a nice decompression as you present, even to the to the uncovertebral joint bilaterally. We are capable to do the drilling. I'm not sure if we should switch our paradigm as toward the endoscope approach. This is the question. Do you think the people, middle-aged group, neurosurgeon should switch to the endoscopic cervical discectomy instead of the ACDF if they feel relaxed to do the regular ACDF procedure microscopically? This is the first question. My second question, lumbar cases that you present, do you do 3 levels with endoscope? Are you capable to do so? And how much time does it take you to do the 3 levels, for example? Thank you so much again for the nice question.
Yeah, hello. Could you hear me, anyone?
I think we hear you, but sometimes you mute all of us. Did Dr. Song receive the two questions that I asked? And can you unmute him to reply
Okay.
to
Could you text?
the
Could
question?
you? Okay. Could you text it in the chat box and WhatsApp group if he didn't respond your questions? So that's the last option we can give. And the other speaker named one lady neurosurgeon. Her name is Johanna Camejo, and she has I think she is in her hospital. She asked for 15 minutes so that she can join. So I think we need to wait, or we should take a break.
Sorry, I heard the second problem, but I don't understand the first one. If I
Yes, please.
Is it the network problem from my side?
okay.
Is it, or I can't find out what's the issue? Yeah, hello, Dr. Johanna. Are you ready for the presentation? Hello? Okay, Dr. Ahmad, could you hear me? Yeah, hello, Dr. Ahmad. Can you unmute yourself?
Okay.
Okay, we request you to start your presentation while Dr. Johanna will present later.
Okay, sure. So I'll start sharing my presentation now.
Yes, yes, please.
Okay, sure. Okay, can you see my screen now? Hello? Please confirm that you're seeing my screen.
Hello, good afternoon. Yes, it's visible. It's visible your screen.
Is it clear? Hello?
Sorry, yes, yes, it's clear.
Okay, great. So I want to share first, but do you see my video? Just not the screen. Let me. I want to start the video as well. Okay, yeah, I think I can see all. Yeah, hello everyone. Thank you for this great opportunity. Okay,
Hello.
so
1 minute, please.
yeah, okay, sure.
Okay, Dr. Damian, I tried to connect with Dr. Johanna several times, but she told that she'll join after 30 minutes. But I think she's still not get herself available to talk. So if you could see, if it's possible, then inform her that the next session will be. Yes, hello?
Yeah, I hear you. So you want me to start my session now, right?
Yes.
Okay, I was just want. So do you see the presentation? I'm sharing my screen. Is it clear?
Yes, yes, it's clear.
Hello? Clear. Okay, great. So let's start. So first, I want to present my topic today. It's about direct transnasal dural suturing after endoscopic hypoglycemia.
Please provide your introduction and then please start the session.
Sorry?
Please tell about your introduction and then start the session.
Yeah, sure. Okay, so my name is Ahmad Abdul Wahab. I'm an assistant lecturer for neurosurgery department in Mansoura University in Egypt. I've spent about 5 years in training residency, followed by a year of being assistant lecturer. And during that time, we have shared a lot of clinical trials. Last of them that we published last year is my topic today. I'm actually very thankful for this opportunity, and I hope you will all get benefit from my topic today. So I'll start now with my topic. It's about direct transnasal dural suturing after endoscopic hypoglycemia. We published that last year in the Pan Arab Journal of Rhinology. First, we will talk about a brief background regarding the history of the transesophageal surgery and the transcellular surgery and how it started. It actually started in the 1960s with it was first described by Harvey Cushing, who first reached the cellular thoracic region with all its lesions and contents with the sublabial approach. Then with the modern neurosurgery and the advancement and the introduction of microscopy, he added that for visualization of deeper structure in the cellular thoracic region. And later on, Jankowski added the use of endoscopy for transesophageal surgery for pituitary adenomas, craniopharyngiomas, and almost all cellular lesions, either with the conventional endoscopic endonasal approach, the traditional way, or the extended and expanded approach. And since then, it has been highlighted to be used as the gold standard almost in all hypervasectomy centers. The gold standard for avoiding pituitary adenomas is the endoscopic endonasal hypervasectomy. Since it's a minimally invasive technique for using the nasal cavity and avoiding the hazards that we put the patient during transcranial approaches, also avoiding the surgical site incisions. But like despite the surgical advancement in the techniques and equipment, it has remained the key issue of the endonasal endoscopic surgery, the cerebrospinal fluid leakage in the post-operative period. So the standard surgical repair methods on almost all centers now. First, we use backing the cellular thoracic region with either autologous grafts like fat or muscle, or even synthetic materials in some centers. Typically, in our center, we use the backing the cellular skulls with fat or muscle. Then we perform medullary reconstruction with either synthetic materials like the fascia lata graft or the fibrin glue. And this can, in some cases, we suspect the C-stiff leakage. We reinforce the cellular region with either nasal septal flap, middle turbinate flap, Hello? I think I lost the connection.
Yes, hello, we can hear.
Hello.
Yeah, did I lose the connection? I was presenting. Where did?
Yes, I think that Dr. Sanchez need to stop share her presentation.
I'm trying. So please just tell me when did I lose my my presentation, because I don't know where did you last reach my. Did I start all over again?
Yes, please. Thank you very much.
Okay. Now, okay, so it's clear now, right? So should I start that all over again? Okay, so my topic, so first I'll introduce myself. My name is Ahmed Abdelhab. I'm assistant lecturer of neurosurgery, Mansour University in Egypt. I don't know, where did I stop, or where did you stop the recording?
You were just reviewing the beginning, like what you use, fascia lata. I think that slide.
Okay, thanks. So after reviewing the history of the transfemoral surgery, and you were talking about the standard dural repair methods. So typically, we firstly pack the cell lateral region with the autologous tissue grafts, either fat or muscle, or synthetic materials, like I mentioned before. Also, after that, we add a dural reconstruction with either cartilage or bone, or even synthetic materials like the fibrin glue or the hydroxyapatite plates. In some cases where the C-stiff leak is still a risk, we reinforce the cellular region with either a nasoseptal flaps or middle turbinate flaps. And all that had came with the downsides of the high cost of the materials we use, the increased morbidities, because typically, like it was proven by Alabed et al. In 2019, that disrupting the sinonasal cavity in order to reinforce the cellular region with either middle turbinate flap or pedicle devascularized flaps, all these disrupt the sinonasal anatomy and the sinonasal function, and that can add a lot of morbidity to the patient later on. We can fix the pituitary issue, but we add a morbidity regarding the oronasal cavity. So all these has came with the morbidity of that, and also we put the patient along a longer operative times, because we're putting the patient at risk of anesthesia, at risk of a lot of complications because of the long operation times. So you're following all? Hello, are you following me?
Yes, yes.
Okay, thanks. So typically, when we first came with the idea of the challenges of the dural closure, when we first came with the idea of the dural closure, we were faced with a lot of challenges. The first of them is the very narrow surgical corridor. Typically, during the endonasal corridor, it's very narrow. Also, with the limited tool accessibility during surgery, because like we all know, one of the principles of surgery and the suturing in surgery, you have to perform it in a horizontal plane. So that's very limited in the endonasal corridor. So that added a challenge for us to perform dural closure after endoscopic hypophysiectomy. Also, later on during the intraoperative period, we found that the dura is very flimsy. It's unlike the skin, it is with limited stretchability and elasticity. So performing a suture in that region with all these challenges is typically hard. So what did we do? We conducted a study after IRB approval, of course, on a total of 15 cases. We performed a simple, innovative technique using already available tools, and that's something I wanted to highlight on. is that a lot of the ideas of dural closure, either by Vanacluca or Tosaka, all these maneuvers were used with the special instruments and the specific maneuvers. And that was very difficult. Like in almost all skull-based centers, we don't have a special instruments for direct dural closure. So that's the advantage of our technique. We use a very simple technique and already available tools. We use the straight Blacksley forceps, a spinal needle, and the endoscope we use for veterinary surgery. Typically, it's either 0 or 30 degree, with the criteria of a 4 millimeter diameter and 18 centimeter in length. And that's found in almost all skull-based centers, so we don't use specific instruments. Before starting our surgery, I want to highlight upon some things about the radiological assessment. We have to be very cautious because the surgery can end before it begins if we didn't revise our radiology very well. Typically because the sphenoid septum can be attached to the carotids. And in that case, we have to be cautious regarding that because we can injure the carotid. Also, we have to prepare ourselves for partial middle turbinectomy because in case of a narrow endonasal corridor, we have sometimes we have to be pushed to perform partial middle turbinectomy to allow us for more accessibility. And in our study, we performed partial middle turbinectomy in 3 cases, number 4, 7, and 9. So during surgery itself, the first thing we have to perform is to optimize the circumstances for dural suturing. So typically, to gain better accessibility, we perform a high posterior minimal septictomy, few millimeters above the level of the most inferior portion of the sphenoid sinus space. And this allows us for a 4-hand binostril endoscopic work, and that can make it much easier for dural suturing. After that, we have to widen the field because, like, typically we have to make the bone edges much further than the dural edges. So we perform a posterior bony opening in the posterior sphenoid sinus wall, and that can be widened by 1 millimeter by Tinkerson forceps to a degree that permits successful dural suturing. During incising the dura, we have to be very cautious regarding the incision shape. We have to be very meticulous to perform a U-shaped dural incision and avoid using any electrocautery and any bovi to achieve healthy, precise cut edges that can be later on sutured. The first step is that we take the bites of the suture by a straight Blacksley forceps in an inside-outside technique. In that manner, we can avoid injuring the carotids, and we typically use a direct dural suture with a 6/0 polydexnone from a 30 millimeter 3/8 needle. Then we perform the 2-point stitch technique, where the sutures are placed at 12 and 6 o'clock positions, respectively. This is followed by performing the upper needle insertion first, and then the lower insertion. And after that, the needle is taken out entirely of the nose so that the 2 ends are outside, and we perform and tie the knot outside the nose. After that, we make the spinal needle to be modified in the shape of a clothes hanger, and we push the knot from outside the nose to inside deeply through the nasal corridor with the guidance of endoscopy. After that, we slightly stretch one end of the suture slightly than the other to allow the knot to slide deeply, also with pushing it by the modified clothes hanger spinal needle. And after that, 2 knots are needed to ensure the suture stability. Regarding our outcomes, we succeeded to suture 13 out of 15 cases to achieve a watertight suture, and that was our goal. But 2 cases was not feasible because of the flimsy dura, like I mentioned before, the limited stretchability of the dura that required alternative reconstruction methods. One case was shifted to nasoseptal flap with the aid of the fascia lata graft, and the other was shifted to the middle turbinate flap with also a reinforcement of the fascia lata graft. We followed up our patients for 2 months, and the patients were closely monitored in our clinic for CSF leaks and any further complications to find that we achieved stable closure in all successfully sutured patients and there was no need for additional surgical intervention after suturing. Regarding our complications, one case only showed an early suspicious CSF leak, but thankfully that resolved conservatively within 1 week without any need for further surgery. And there was no long-term CSF leaks observed in our study and no cases of meningitis or other severe complications. Like I said before, we were not the first who came with the idea of the direct dural suturing. Varak Luka proposed that idea with the use of microscopic interrupted and running suture using special instruments, and that's something to put in mind. Special instruments and are not tying forceps he used. And also to Saka in 2021, he considered suturing hard tissues as bone or cartilage to the defect site, placing 2 holes in to help place sutures. And also he used hydroxyapatite blades with the sutures passing through its 2 holes. He made like the hydroxyapatite blades in Saka's study was already made with 2 holes to suture directly. In a review article in 2021 was made by Nishioka, he pointed out that suturing the dura enhances its healing even if the sutures are not watertight. So the watertight seal was our goal, but even the approximation of the dura with suturing without performing a watertight seal, even that enhances its healing. And that gave us a lot of courage in our study. So our new method of sutures can be done simply in cases of intraoperative CSF leaks with no need for special instruments or difficult technique. We use tools that are already available in almost all skull-based centers. The straight Plaxi forceps and the spinal needle, and these are easy to use surgical instruments. And the knot tying procedures we perform, it does not need a specific maneuver rather than just pulling asymmetrically steadily over one end with the help of the bent spinal needle. So what are the benefits for direct dural suturing? Like I said, the achievement of the watertight seal, that was inadequate in the traditional repairs like the fasciolata graft, the cellular reconstruction with middle turbinate or partial middle turbinate. All these lead to inadequacy in achieving watertight suturing, and that led to the potential complications of meningitis, encephalitis, and even death. So direct suturing of the dura offers better closure and can prevent the need for any additional materials with all its costs and and longer operative time. So we had some limitations, like you can see in the sample size was small. So we need larger cases for validation. Also, the training and skill requirements in the initial cases, we needed technically demanding maneuver of performing the suture outside the nose. And to perform that smoothly, it was time consuming in the first cases. And that regarding the performance made a steep learning curve just in the initial cases. Then later on, after practicing well outside the OR, it was smoothly done inside. In the future, we hope to apply that for high flow CSF leaks because our technique was primarily used in low flow cases. So more research is needed in that regard to assess its effectiveness in high flow leaks. In conclusion, the endoscopic direct dural suture of this simple technique is the efficient method in hypophysiectomy cases. Just larger cases are needed for validation. Thank you. Hello?
Yeah, yes, hello. Thank you, Dr.
Yeah.
Ahmad, for the
You're
beautiful
welcome.
presentation.
Thanks.
Hello, Dr. Johanna. Are you available to start your presentation?
Yes, I'm available. Hello, everyone.
Great, that's yeah. Thank you so much.
Really,
You are the
I'm really
lady.
sorry for the inconvenience. You know, the issue with
okay.
my.
That's okay. You are the first lady neurosurgeon in this webinar.
Okay, so did you all can see my presentation?
Yes.
Yes, it's visible. If it's possible, try to change to full screen. I think will be better. Like this.
Okay. So did you can see? You can hear me?
Yeah, all clear.
Okay, thank you so much. Again, I'm Dr. Sanchez, Dr. Joanna Camijo Sanchez, Cuban neurosurgeon. And it's a pleasure for me to present to all of you a case report of craniosynostosis and myelomeningocele in iCardioid malignant syndrome. So just to remind that the iCardioid syndrome is a rare genetic disorder of neurological development and is based in a dominant inherentic of the chromosome X chromosomes. And for this reason, it affects most of the time the women, males only with the Klinefelter syndromes. And it's also a syndrome characterized by a triad of agenesis, of hypogenesis of the corpus callosum, chorioretinal lacunae, and infant spasms. According to an study in US in 2008, the prevalence of this syndrome around the world is approximately 4,000 cases. And regarding to the incidence rate, it varies between 0.63 and 1 per 100,000 live births. This is just to demonstrate that it's a very rare condition. This syndrome was described before for a Professor Jane Icardi in 1965, but just some years later, in 2046, Krauss et al. Just find a patient, a girl, with a chorioretinal lacunae with associated with seizures, epileptic seizures. But after Sutton et al. Just expand the clinical spectrum and propose a new diagnosis criteria. This diagnosis criteria proposed for Sutton is the one that we usually use in our practice to diagnose these syndromes. So all of us, we know that the diagnosis of Icardi syndrome is a challenge because there is not available the genetic study, genetics test to diagnose this kind of syndrome during the pregnancy and also after. So just with the clinical presentation and the finding in the imaging study, we can make the diagnosis. So usually the criteria is first of all, if the patient has one of the classic triad proposed for Icardi. The second one is if the patient present two of these classic features or at least two of the suggestive features. These suggestive features, we call it the cortical malformation, also intracranial cyst or optic nerve hypoplasia. About our case report, we received in our hospital a patient, a girl, 4 months old, and she developed with multiple episodes of generalized spastic seizures. in the upper limbs because she was not able to move the lower limbs. Also, the loss of appetite, weak suckiness, and skull deformity. On the physical examination, we can find the scaphocephaly, signs of malnutrition, and also with the muscular atrophy, cervical, the dominance of the cervical was really avoided, and absent of spontaneous movement, hyporeflexia of the lower limbs, and also in the sacral lumbar region, we can find the mass suggestive to spina bifida or MMC. We request the MRI, and we can find in the MRI the agenesis of the callium corpse, and also this paraventricular cyst with the microhyria, suggestive to Aicardi syndrome in this patient. As a surgical treatment, usually right now, what we do is make a multidisciplinary evaluation with the ophthalmologist, neurosurgeon, and also general surgeon with
Yes, hello. Yeah, hello. Please continue. Madam, please unmute yourself. Dr. Sanchez, please unmute yourself.
I think that Dr. Sanchez should unmute.
Yeah, hello,
the
Dr. Sanchez.
maybe by WhatsApp group I can contact her. Let me see.
Okay, I'll message. I messaged her in WhatsApp, but I think she's very busy in talking. Dr. Damian, could you able to inform her?
Yes, Anjali, I already sent her a message. I hope that she will be able to see the message. We'll see. But it's evident that she cannot hear us.
Okay, now that you can hear me now. No
Dr. Sanchez, I already opened your audio. Okay, now it's okay. You can speak.
Okay, did you see my presentation?
Yes.
Okay, so about the treatment, that so I was telling you that usually in our practice that this kind of cases, we make a multidisciplinary review with the ophthalmology, pediatric surgeon, and the neurosurgeon. For this case, so we decide to treat the craniosynostosis first because it was causing a severe intracranial hypertension. Also to repair the myelomeningocele. And after that, we just decide to wait if we don't need to do surgery for the epileptic. After this kind of surgery, so we decide to treat the seizures and see how it's going. So as surgical treatment, we perform bilateral linear parasagittal craniotomy, and we repair the MMC. So you can see we make a linear incision. We made the bilateral craniectomy, and we repaired the MMC. Just finished the surgery. We were so happy that we can hear the baby crying. Before surgery, she was not able to, the suckiness was absence. Also, the baby was not crying. And that was 3 months post-op. So the MMC was already repaired. The patient start, I don't know if you can see here that the patient start just to move one of the lower limbs. And about the head, if you can see the size of the head and the skull deformity was treated. Thank you so much. If you have any questions.
Thank you so much, ma'am, for your beautiful presentation. Thank you so much, doctor. Yeah, could you hear me?
Yes, yes, I can hear you.
Yes, thank you so much. Dr. Damian and Dr. Gabriel. Dr. Bambang also present. Do you have any questions for her?
Very complicated case. Congratulations on that case.
Thank you so much. Thank you so much. I'm really sorry for all the inconvenience with my presentation. Hope next time it will not happen.
Dr. Gabriel is asking something. Let us wait to repeat him again. I think there was a connection lost. So let us wait for a few minutes.
Hello, sorry. I was busy here in the hospital, so I didn't get the opportunity to hear the whole conference of Dr. Sanchez. But I was part of the team who performed this surgery, so I have a question for Dr. Sanchez, if it's possible. I don't know if you can hear me.
Yeah, I saw that Dr. Gabriel has been asking something to her, but suddenly Dr. Gabriel lost his connection. So we need to wait, see. Yeah, he rejoined again.
Okay, so I was reading on the chat that Dr. Gabriel was asking, but I think it was for the previous presentation, was about pituitary gland. So I think it's not for me.
Sure.
Yes, I was reading on the chat that he was asking something about the pituitary lesions. So I think it's for the previous presentation.